therapy, which is the Zolgensma, which is trade name, and the generic is onazimnogene abibarvovich. And then in 2020, the oral SMN2 splicing modifier was also approved. So now we have 3 advanced therapies for SMA at the moment. Now, one thing to understand is that the benefit of these therapies really is more early on. So the window of opportunity, i.e. the time when you can rescue the motor neurons, is short in type 1. So it's best when you catch them pre-symptomatically. But for type 1 who do not reach the point of sitting, it's measured maybe in weeks or few months. Type 2 is probably a little bit longer. Type 3 is a little bit longer. Type 4 is somewhat longer. The point here is these therapies help to maintain the surviving neurons and do not recover the dead neurons. What we suffer from this is the delay in diagnosis. And this is a study that showed that the delay in diagnosing type 1 from the onset of symptoms at 2.5 to the diagnosis at 6.5, so it's about 3 months delay. This is huge for type 1. By that time, they're quite symptomatic, and the benefit really goes down. Type 2 is even longer, and type 3 is much longer. So this delay is the window of opportunity where we could have intervened earlier. This is another study which looks at the motor unit number estimation, meaning that we estimate the number of motor units by electrophysiological assessment. And in type 1, you see the rapid drop in the first few months. Type 2 is a bit slower, and type 3 is again slower. Let me just turn this off. Anyway. So the point here, again, type 1 is really an emergency. It's very important to recognize this kind of window of opportunity. This is about the natural history of SMA1. Now, all the studies that led to approval of these therapies were done on type 1 because it has a clear progression, clear natural history, and therefore if you intervene, you will see the difference in a short period of time, as opposed to type 2 and type 3, which is a little bit quite slower. And so that's what happened. If you look here, these are 2 cohorts, natural history cohorts. By 8 months, 50% are surviving. And then by 20 months, 8% are surviving only. And so that means survival or permanent ventilation, which means that this is a deadly disease. Now, I did not put data here on all the trials that were done, but I can assure you that most, if not all of the trials, led to a line almost straight, meaning most, if not all, patients were surviving during the trial period, type 1. So these drugs are effective or efficacious. This is just a summary of the options or therapies that are available. If I can just guide you in this busy slide, this is the mechanism of the therapy. Those 3 increase the SMN1 level, and those 2 are SMN independent. They're not action on the SMN protein or SMN gene. If you look at the SMN dependent, of course, the gene therapy or the gene replacement, which is the onazimnogene by Novartis, basically it is a viral vector that carries the missing gene. They inject it intravenously, one-time injection, and then it's given usually to patients below age 2 years and the FDA approval, and in Europe 21 kilos, so they can go up to 4 or 5 years. But it's a weight dependent. It's given one time, and then you see the effect lasting a couple of years. Actually, the 6-7 years, they're still benefiting from the medication. The 2 therapies here, the intrathecal, which is the first drug approved, which is the nusinersen, is given intrathecally. It acts on SMN2 by causing blocking the alternative splicing, and the result is more production of SMN protein. The same for the risdiplam, which is by Roche, is given orally, but this is an antisense oligonucleotide. This is a small molecule compound. There's another one that is another drugs that are in the pipeline which act on the myostatin inhibition, meaning promoting muscle growth and other effects, or antioxidant, etc., etc. So the availables are the first three, but in the pipeline, many. So what have we learned from all the clinical trials? I can tell you more than 20 clinical trials have been done or ongoing. So what have we learned from the clinical trials and the real-world evidence that is published so far? Number one, the earlier the better. So if you treat the patient early, and the best is pre-symptomatic, meaning before symptom onset, you get the best results, almost near normal. We know that these therapies are not curative, they are just treatment, they modify the disease, but now we know if you treat them earlier, the result is much better. And the other thing is, of course, those who are stronger will benefit more, and if you have a shorter duration of disease, that's also another predictor of improvement. So the benefit is early, short course, and stronger patients, and there are scales that we use to assess the strength. All therapies are cost-effective. You know, I'm not a health economist, but all the studies that were published about the cost-effectiveness, cost-impact, etc., they show that they are cost-effective. Some of them are superior to others. Like, for example, giving gene therapy pre-symptomatic or in the first 2 years is probably more cost-effective than the other intrathecal or oral. In older patients, maybe giving the oral is more cost-effective because of the cost, of course. So there is some variability, but all of them are cost-effective. We don't know whether this one is superior to the other one, so comparison head-to-head is not available, and therefore really saying this is better than the other clinically may not be easy. Same is for combination. So if you give gene therapy at the beginning and then you give them top-up nusinersen or risdiplam, would that be superior to just giving them the gene therapy? Again, it's part of the unknown that we are learning. Now, the benefit is much more robust, as I mentioned, to type 1 and pre-symptomatic, but type 3 or adult types, the benefit is a little bit not that strong. And so therefore, now the notion is just stabilizing the disease, the goal that we should aim for adults and adolescents with SMA. Again, this is something that we are still in a learning curve with that. This is just to tell you the impact of these therapies, the earlier the better. Please tell me about the time, Tara, I don't know. Or when you stop me, I will stop. Now, this is a graph I took from a paper. Sorry, I did not put the reference here, but I have it. This is just to show you that the pipeline of medications that are coming, or some of them are in use, is huge. So it's just, we're talking about these, the antisense and the gene therapy, the three ones, the three are the main. But there are others that are used that have some modest effect, or some of them are still in trial stage. And therefore, down the line, maybe what we will have is a cocktail of therapy to patients, not only one treatment, but probably we'll have a myostatin inhibitor in addition to gene therapy, or another HDAC inhibitor plus the other gene therapy, etc. Now, with all these changes and developments, the management or the field of SMA care has really transitioned or transformed tremendously. In the past, you know, the diagnosis of type 1 is like almost a death sentence. You can say this is diagnosis, no code, and unfortunately, there's no treatment, no hope. It was fragmented care. In the 2016 and then 2018 was the updated standard of care that really highlighted the importance of a multidisciplinary team with the patient in the center, and addressing all the aspects of SMA care, starting from diagnosis to rehabilitation, orthopedic care, nutrition, palliative, pulmonary, etc. So the disease, it's not a disease of muscles, it's a disease of multiple systems. And the most important systems are the skeletal system, the respiratory system, nutrition, and bulbar function, in addition to the impact on mobility and life activities. So coming to the most challenging part is what has happened to Saudi Arabia's practice of SMA. As for the diagnosis, I can tell you, like from before the advent of these therapies, the average age at which we diagnose SMA, but that's a tertiary care bias, is about 10, 12 months or even older. Now, with the availability of therapy and diagnostic testing, patients are diagnosed at age 3, 4 months. The problem we have here is even at 4 months, when they come, they are quite weak. So they really lost a great amount of their motor neuron pool, and therefore therapy has maybe a limited effect or benefit on those patients. Again, partly it's because we have a severe phenotype of even type 1, so that's another unfortunate thing. We do not have a newborn screening program, which I hope that comes as one of the recommendations for this disease. This is a chronic disease. It's a disabling disease. Early recognition impacts care, as you have heard. And so screening at birth is very important because you can intervene before symptom onset. So it qualifies for a disease that is worth screening. And in fact, screening programs are now expanding almost in all Europe, most of the United States, Canada, some Asian countries. But I think in Saudi Arabia and the GCC is still not yet well established. Of course, there are pilot trials, studies, but it's not. I think it's very important as well. 2 minutes only? Then I have to speed up. The late referral is another one, and that I mentioned, and then the availability of antenatal diagnosis, because that will be another alternative for this, and the phenotypic severity, which I mentioned in our case. Standard of care is not existent in most places, and multidisciplinary team approach is also not existent. The cost and selection of therapy for patients, luckily we have a National Ministry of Health committee that looks at, selection and criteria and outcome, etc. So that's helping. And the other thing is prevention through premarital screening, pre-implantation genetic diagnosis, and high-risk screening is really what we need to prevent this disease, because the best treatment is prevention. It's cost-effective, clearly. Considering the cost of gene therapy is $2.1 million for one patient. The Spinraza is $750,000 first year and then $375,000 subsequent years. The other one, between depending on the age and the weight, is around $100,000 per patient. So you can do screening program for treating one instead of treating one patient. So this is my recommendation, which I alluded to, having a newborn screening to catch the new patients coming, and expanding the MOH program to capture the data, the outcome, and the management improvement, like the establishing the MDT treatment, and the prevention, as I mentioned, through universal premarital screening, high-risk screening, and PGD. The other thing is education, both to professionals in how to address and treat those patients preemptively, and public awareness about the disease. It's really quite common in our country, and therefore they have to understand the importance of standard of care in addition to the other gene therapies. We've received patients looking for treatment. They have very bad contractions, very weak, so they lost the opportunity to improve, but yet they think this is a cure. It's not a cure, and we know this. This is just to show the cost, but I will stop here. This picture actually just to show you. باقي دقيقة ولا دقيقة واحدة. This is just a picture to show you that it's a disease of children that can be intubated, ventilated for life in type 1. It's a disease for a family that will also suffer even with one patient who is disabled. It's a skeletal disease. It's a multi-system disease. It's even a disease of adults. So it's a disease of the entire age groups. And this is my, I think, last slide. I took this from a video. Actually, it's present in the internet, and from a presentation by Laurent Servet. He was talking about a family. They diagnosed the first one, treated him after symptom onset, and his sister was diagnosed pre-symptomatically, treated early. Now, after 5 years, the girl is running, biking, and the boy is wheelchair. Yes, he survived, but he is wheelchair bound. So window of opportunity, and pre-symptomatic treatment should be the goal. I think that's it. Thank you very much.
Thank you very much, Dr. Muhammad. We will leave the questions and answers at the last. It's my honor to introduce our second speaker, Dr. Amna Al-Ftaisi. Dr. Amna is an associate professor in child health at Sultan Qaboos University. She's also the president of the Society for Anti-Epilepsy and the vice president for the Neurological Society in Oman. She will be addressing to us the etiology and outcome of children with epileptic encephalopathy at the tertiary care center. So please, Dr. Amna.
Assalamu alaikum wa rahmatullahi wa barakatuh. It gives me a great pleasure to be among friends and family, and I would like to thank the organizing committee for their kind invitation and congratulate them on the successful and excellent conference. Now from hope to a more darker area in epilepsy and in neurological diseases in children. Epileptic encephalopathies that pose a great challenge to the clinician and the epileptologist or neurologist from infancy to adulthood. These disorders are characterized by intractable catastrophic epilepsy with impairment of cognition and development, and consequently it also affects the family as a whole, where they have to face a lot of challenges dealing with those children. So now I'll take you through a journey to discuss the concept and evolution of epileptic encephalopathies. I would also touch base quickly on some types of the epileptic encephalopathies that we see in children, and the main focus will be looking at our data, looking at patients with epileptic encephalopathies at Sultan Qaboos University Hospital, and together we can discuss the importance of such findings. In 2017, the International League Against Epilepsy redefined epilepsies, and in general, we as neurologists like to complicate things. So, but actually, I find this classification is much simpler, more straightforward, and describes these types of seizures and epilepsies in a simpler way in patients. So there was the seizures types has been redefined to a focal and generalized, and then there is categories of unknown, so we don't know where to put those seizures, like infantile spasms, where they could be because of focal causes or generalized causes. Then, based on this classifications of seizures, also epilepsies has been reclassified into focal and generalized epilepsies, or combined focal and generalized epilepsies, and then the unknown. If you remember previously, we tend to say complex partial seizure, simple partial seizure, and all the types of generalized seizures, which is not there anymore. Depending on this classification, they have added to the classification etiology, and this is to emphasize the importance and contribution of various etiological factors with the impact on the epilepsies, and also the comorbidities, because we know that a lot of these epilepsies are associated with different comorbidities, especially behavioral and neuropsychiatric manifestation like OCDs, ADHDs, learning disabilities, and these actually might be a big burden on the management of those patients. Then eventually we also have to make really huge attempts in terms to classify those disorders and fit them into an epileptic syndrome. Although I have to warn you that we don't always succeed into fitting everything into an epileptic syndrome, but fitting the epilepsies into epileptic syndrome is very important for the management of the patient, for the counseling, for the prognosis. When we counsel the patient, is this a self-limited epilepsy, or this is like an epileptic encephalopathy, and we know that there are catastrophic implications to this diagnosis. If now we look at the term epileptic encephalopathies, if you remember or if you are aware, infantile spasms was described by Dr. West, and this is the West syndrome that everybody is familiar with, which describes a particular set of seizures, infantile spasms with developmental delay and Hibs arrhythmias on EEG. And this was described in 1841 by Dr. West on his own child. However, although many disorders came then, the term epileptic encephalopathy only started to materialize in the 50s, and eventually in 2001 it was added to the classification of the International League Against Epilepsy. As I said, there were always multiple efforts trying to really have a look at the classification. So there was redefinition in 2006, another revision in 2010, and eventually in 2017 we have a newer classification. This is an EEG of a patient with burst suppression pattern, and even without hearing the clinical story of the patient, if I see this in the EEG lab, I will know that this patient will have most likely will have a grave diagnosis and prognosis and outcome, with some exceptions of the treatable metabolic encephalopathies. In 2001, the International League Against Epilepsy emphasized that this is a condition where the epileptic abnormalities that we see on the EEGs are believed to contribute to the progressive disturbance in the cerebral function, i.e. the development and cognition that is impaired in those children. In 2006, another three factors were added to the definition, and those are the epileptic activities, the etiology, to emphasize that also it's not the epileptic activity, but also the causes may contribute to the dysfunction in those children. And also they added the impact of anti-seizure medications, and we know that anti-seizure medications have impact on cognition in people treated for seizures and epilepsies. In 2010, it is defined as an epileptic activity that itself will contribute to the severe cognitive and behavioral impairment we see on those children beyond what is expected for the underlying pathology. So here they are emphasizing the contribution of the epileptic abnormalities that we see on the EEG. They also added another dimension that those children also, it's not just developmental delay, but also they may regress when they start to have their epileptic encephalopathy. In 2017, it is defined that an epileptic encephalopathy is the abundant epileptiform discharges that we see on EEGs contribute or interfere with the development, resulting in cognitive slowing, so the impairment or regression of the milestones. And also they added the associated comorbidities that I have already talked about. So if you look at this graph, there's a concept of epileptic encephalopathy and a concept of developmental encephalopathy. So if we manage to suppress the epileptic activity, then the resultant will be developmental encephalopathy. And those patients, they may have now the contribution to the development is because of the cause or the underlying pathology the patient have. If the epileptic encephalopathy is increased, the resultant will be epileptic encephalopathy. There will be also contribution of etiology, but the more emphasis will be because of the increase in epileptic encephalopathy. Developmental delay will be variable depending on the epileptic activities or the abundance on the EEGs, and also the etiology contribution. So if we look at those disorders, it's an umbrella of disorders. Yes, the concept is one, but there are many disorders, as you will see, that we have to deal with. Those disorders are age-dependent, so we know that early onset neonatal epileptic encephalopathies like Ohtahara syndrome, early myoclonic epilepsies, usually in the first month of life, and they could appear as early as 2 to 3 days of life. Infantile spasm, we know, characteristically starts around 5 to 6 months of age, and so on. They also have a unique type of seizures, so although early infantile epileptic encephalopathy has several seizure types, likewise early myoclonic epilepsies also have several seizure types, but we know that in early infantile epileptic encephalopathy, tonic seizures will predominate, and in early myoclonic epilepsy, myoclonic seizures predominate. Those children invariably have abnormal interictal EEGs. So if you do their EEGs and they don't have seizures, they don't have at that time, still you will find there is very active epileptiform discharges. Usually there is a wide array of disorders or causes that may cause these disorders or epileptic encephalopathies. You have from genetic, metabolic causes, hypoxic ischemic encephalopathy or perinatal asphyxia as contributing to the many causes of epileptic encephalopathies. They also very resistant to medications. Most of the time you'll see that those patients are on 3 or 4 anti-seizure medications. We may resort to also use other modalities of treatment such as ketogenic diet, vagal nerve stimulation, and surgical interventions. And of course, as a consequence of this, these children also most often have developmental delay, and some of them are characteristically have regression as well or loss of milestone. So if we look at the patterns of development in children with epileptic encephalopathies, those children, they may have a pre-existing developmental delay and then they worsen or they just stay the same or plateau when their epileptic activity starts. They may have a background of normal development, and the most classic phenotype is Dravet syndrome, and this is usually in Dravet syndrome those children has normal development, and once the epileptic activity starts, then we will see slowing in their development, and you will have patients and parents telling you, oh, I have noticed that my child is not doing such things that he was able to do before. Or they will end up with permanent developmental impairment depending on the severity of the epilepsy they have. So if we look at the umbrella of disorders, and this is not an exhaustive list, but in the infantile period, as I have mentioned before, we have Ohtahara syndrome, early myoclonic epilepsy, infantile spasm with syndrome, and Dravet syndrome. And in early childhood, we have Lennox-Gastaut syndrome. I think many of you are familiar with it. And then we have the epilepsy aphasia syndromes, and those are continuous spike wave during sleep epilepsy and Landau-Klempner epilepsy, and there are other that I have not mentioned. This graph shows that epileptic encephalopathies are not only important for the pediatric neurologist, but they are also important for the adult neurologist, because these disorders stay throughout life, and although in each period of time, as I have mentioned before, there are classic disorders that appear depending on the age of presentation of that syndrome. However, most of these persist to adulthood, and the knowledge of epileptic encephalopathies is very important, because now we are in the era of precision medicine, and with the advances in genetic mechanisms and genetic investigation and the pathophysiology of diseases, as we have seen, it has transformed the outcome in patients with SMA. It's also has playing a great role in the identification and treatment and targeted therapy for specific disorders like Dravet, for example. There are certain medications that are not to be used in Dravet syndromes, sodium channel blockers, so the adult neurologists need to know that they should not be using like the pediatric neurologist. And also there are certain medications that improve the epileptic activity on those children, so we have to be aware of the advances and the genetic mutation, and we target our therapy tailored to individualized patient genetic mutation. However, despite the advances and the knowledge, there is a huge gap in our knowledge for epileptic encephalopathies, and there are few studies that are conducted in the region and in Oman as well about the disorder. Here we attempted to look at the clinical and etiological profile of children with epileptic encephalopathy in the country and describe the outcomes of those children. This is a descriptive, retrospective cross-sectional study conducted between 2016 to 2021, where we looked at 110 patients who fulfilled the criteria of epileptic encephalopathy according to 2017 ILE definition, and excluded 20 patients because of missing data, basically. We collected data regarding age of onset, age of diagnosis, and outcome, and EEG findings and MRI findings. Most of our patients, there is no sex or gender predilection, and almost half and half males and females. You will see that most of the patients present during the first year of life. Most of the patients present with abnormal movement, where 75% presented with seizures as their first presentation. The most commonest type of seizure is generalized tonic-clonic. As in the rest of the Gulf countries, there's a consanguinity rate on those cohort of patients up to 55%. And 44% of patients has significant findings on their MRI. If we look at the epileptic encephalopathies, what is worrying is still that there is a subset of patients that we don't have a cause for their epileptic encephalopathy, and I believe that maybe there is a new genetic mutations that are or genes that are still not discovered, and we have to look at those patients more critically. If we look at the outcome and seizure control on those patients, you will see that 75% of those patients are on 2 medications or more, signifying that those patients has really very poor outcome in terms of their seizure control. Looking at development, both motor development and language and speech, you see that 95% have some kind of delay, and around 63% or more, they needed assistance for mobilization, and some of the majority were bedbound or limited mobility. There are still limitations to the studies, such as the retrospective nature. We are also missing the huge data from another tertiary care center, the Royal Hospital, and some missing data in patient records. So the clinical and etiological profile of children with epileptic encephalopathies in Oman or in our center looks like similar to what has been in the literature. This population seems to have a higher rate of inherited disorders and high rate of consanguinity. Poor seizure control is prevalent, and most of the patients are on multiple medications, and most of them have developmental delay. For the future, we need more large multi-center prospective trial studies with more maybe genetic ascertainment of the cause, and studies to study the outcome and the impact on the children and the families, because those children will need a lot of resources to deal with the consequence of delayed or impaired development. To conclude, epileptic encephalopathies are developmental epilepsies with severe EEG abnormalities, relentless seizures, and poor outcome. In the studies, epileptic encephalopathies are highly associated with inborn errors of metabolism and genetic disorders, and poor seizure control is seen, and there is and this consequently will impact the development of those children. However, further studies are needed to better understand the etiology and impact of epileptic encephalopathies and developmental epileptic encephalopathies in the country. And thank you for your attention. Thank you.
Thank you very much. We go ahead with our third speaker, Dr. Munira Al-Dahi. Dr. Munira is an assistant professor in Health College and Rehabilitation at Princess Noura bint Abdurrahman University, and she is also the vice president of the college and the research center related to this. She also chaired the respiratory therapy program and the physiotherapy program at King Abdulaziz University. So
spinal cord injury. So finding of that work really struck a chord with me and made my scope more specific in order to study the mechanism underlying this decline in the cardiac output. Why there is actually during exercise there is a decrease in the cardiac output. Why the slowness presented there among these individuals with complete spinal cord injury during exercise. So we conducted this study that looked at modulation of the left ventricular diastolic filling among these individuals. And if you look at the by the balance among, sorry, it's not appearing there, the stroke volume is regulated by the balance among the inotropic condition of the heart, which is the contractility of the heart, and the afterload and preloading condition. So these are the three determinants of the stroke volume that actually play a major role in increasing that stroke volume. And for the heart to function effectively as a pump, it should not only be able to eject blood, but also fill with the blood. So the filling is considered a crucial period that compromises 2/3 of the diastolic function. It reflects the capacity of the ventricle to actually appropriately fill during the diastolic phase to pump sufficient amount of the blood relative to any metabolic demands. So the diastolic filling, as I mentioned earlier, it's actually comprised 2/3 of the cardiac cycle, and also consider a dynamic process essential in the efficiency of the cardiac performance. So if we look at the preloading condition of the heart, we will see that actually there is a factor that mediates the changes in the preloading condition of the heart in general, not only in spinal cord injury. And these mediators include the peripheral circuit, which is the muscle pumping capacity and the respiratory muscle function, in addition to the cardiac sympathetic pathway. Okay, so let's talk a little bit about the muscle pumping capacity. The muscle ability to contract, it actually play a major role in increasing the preloading condition, because it's induced that intramuscular pressure that accentuate the rate of the filling of the heart. Also, the respiratory muscle pump play a major role as well. It affects the venous return to the heart through the changes in the right atrial pressure, which is important for pressure gradient that increases central venous pressure. Okay, so collectively, these play a role in addition to the cardiac sympathetic pathway in modulating the end-diastolic volume and the filling as well of the velocity of the filling, and eventually augment the stroke volume. So if we think about this, any redundancy in any of these three mediators could actually has a negative impact. And in spinal cord injury, patient with incomplete spinal cord injury, and in particularly I'm focusing here on cervical, these patients actually demonstrate with pattern of the sympathetic deafferentation, partial deafferentation of the spinal cord. And in addition to that, it's not only the sympathetic deafferentation or desegmentation of the spinal cord, also they have a pattern of muscle paralysis that attenuate the vasopressor response below the level of the lesion as well. So any deficiency of these factors could have a negative impact on the filling and the preloading condition of the heart, and could explain this, and could be the potential to explain the decline in the filling. And that's what we tried to actually look at it in that study. It's so interesting that there is a limited study that looked at that despite the high prevalence of patients with incomplete spinal cord injury. Most of the study that use animal model in which the spinal cord injury is completely transaction and the focused primarily in a complete system breakdown. However, the pattern of incomplete spinal cord injury, they represent a completely different pattern, and it's just hard to apply these findings from the complete spinal cord injury on patient with incomplete spinal cord injury. Limited have been done to underline the effect of cervical injury of the spinal cord injury on the ventricular filling and the cardiac loading condition. Therefore, we have looked at the in our study at the modulation during exercise of the left ventricular diastolic function during circulatory challenge exercise, and what I mean by that is the incremental arm ergometer exercise among these individuals with incomplete spinal cord injury. So it was a cross-sectional study conducted at Washington, D.C. and was approved by the George Mason University. And in that study, we have a total of 16 patients included in the study, and they are between the age of 18 to 65. We have inclusion and exclusion criteria. I'm not going to take time on it, but the main criteria is that these patient has to be at AJA C and D and incomplete cervical spinal cord injury, and they should have no history of cardiovascular disease or using any cardiostimulatory medication. So we have them come to our lab for 1 day, where we assess the respiratory muscle function using the spirometry and the respiratory pressure meter to look at the respiratory muscle strength. And then after that, we give them a break for 10 minutes, and then we conduct the testing where we assess the left ventricular performance during the exercise using the bioimpedance cardiography. Bioimpedance, it's one of non-invasive technique that help to capture the cardiac function during dynamic activities, and in particular in this case during arm ergometer exercise. Plus the left ventricular performance testing, we did look at the oxygen consumption during exercise, breath by breath, where we assess the VO2, which is the oxygen consumption during the arm ergometer exercise. And the primary outcome measure was end diastolic volume, left ventricular filling, stroke volume, cardiac output, in addition to assessing the inotropic, which is the contractility of the heart, and the heart rate. Our protocol, as I mentioned earlier, it was incremental arm ergometer exercise till the volutional exhaustion. So the endpoint has to come from the patient. He has to call it off, and plus we have our parameter to tell us that he reached actually the exhaustion. It was discontinuous protocol. What does that mean? We start with 3-minute warm-up at 0 watt, and then every 1 minute the protocol increased by 5 watts, where we give the patient break every 3 minutes for 1 minute. So this is, if you see, this is the consent diagram that actually present the subject that the subject included in the study. A total, as I mentioned, 16. 8 of those patients incomplete spinal cord injury, and 9 healthy, able-bodied individual. However, they are sedentary. Looking at the demographic characteristic, the main thing here is that we have age-matched and weight-matched able-bodied control subject. Patients with spinal cord injury, they are actually 5 to 9 years post-injury, and they presented with C and D age scale. Let's look at these findings. Starting with the exercise performance in order to prevent any bias in our results, so we did assess the patient at 25 and 50 and 75% till the peak 100 of the workload, and then we did assess them at isomax. What does isomax mean? That means at a workload identical to the workload achieved by the spinal cord injury. So we look at the comparison between the control and the spinal cord injury at the same workload to look at the comparison or the differences in the outcome of interest. So what did we find there? That the peak workload and the oxygen consumption was significantly low among incomplete spinal cord injury, despite the lack of differences in the duration of exercise. In terms of the diastolic filling velocity, there was actually a significant decrease among individuals with incomplete spinal cord injury. Within a group of spinal cord injury, the end diastolic filling increased significantly, as you see there, above the resting, and plateaued, as you see it there, after the 50%. There was no increase despite the incremental increase in the workload. If you look at the blue line, those are the control able-bodied. They show the pattern of stepwise increase in the end diastolic filling velocity with increasing the workload. There is a huge differences between the two groups, even not only at 50, 75, and 100, but also at the isomax at the same workload. Looking at the preloading or the end diastolic volume, we will see that there was lack of significant increase. There is a slightly increase if you see there the blue line, but it was not significant at all from the 0 to 25 and then till the end 100, which is interesting, despite increasing in the workload among these individuals, and this is warning sign. If you see there, the green one, there is lack of increase in the volume loading among these individuals, and this is actually the patient with the healthy able control subject. They show the pattern of stepwise increase in the end diastolic volume. At the isomax, again, there is actually a decreases in the both the end diastolic volume and the filling at the isomax as well compared to able-bodied individual. Also, in terms of the cardiac output and stroke volume, actually there was a decrease among these individuals between the groups. Investigating the contractility of the heart and the heart rate to be able to rule out the mechanism underlying this decline in the stroke volume, we did not find any actually differences in the contractility of the heart at the isomax and the chronotropic factor at the isomax as well. In terms of the breathing, is there any actually differences in their breathing pattern? Yes, the respiratory muscle strength was weak, and also the breathing pattern, in particularly the minute ventilation and the frequency was high, which tells us actually there is increased work of breathing among incomplete spinal cord injury patients. So take-home message from this, that those individuals with incomplete spinal cord injury in our study had reduced left ventricular preloading and diastolic filling ratio compared to able-bodied individual, even after adjustment for controlling for the effect of the chronotropic and inotropic factors. The decline in the end diastolic filling and the preloading condition was concomitant as well with the decrease in the stroke volume and the cardiac output during the arm ergometer exercise. This is really interesting because that highlights that the rule of the muscle pumping capacity, the smaller the muscle mass, the less the venous return going to the heart, and that could be a factor that playing a role in that decline in the venous return. Also, we did find there is a concomitant decrease in the filling ratio that actually concurrent with the end diastolic volume. The lower the end diastolic volume, the slower the rate of filling as well. It's possible that other alternative mechanism may play a role in this, and one of these factors is the ionotropic. However, the significant effect of ionotropic condition is not signifying in this case, as we did not find any differences in the chronotropic and ionotropic factor of these individuals. So we ruled out the effect of the cardiac contractility as a factor that decreasing the end diastolic volume. However, can we rule out the respiratory? We couldn't, because there is actually decline in the respiratory muscle strength and increase the work of breathing among these individuals, which highlight that this is also another factor that contribute to the decrease in the end diastolic volume. So this study overall providing a preliminary evidence of blunting diastolic function in response to increase or relative to increase in the workload among individuals with incomplete spinal cord injury. While a many factor could play a role in this, but more dominantly the blunting, it actually limited by or governed by the restriction in the muscle pumping capacity and the respiratory muscle pump among individuals with incomplete spinal cord injury. What can we take home from this? There is actually physiological perspective and clinical relevance. From the physiological perspective, the decrease in the stroke volume among these individuals with incomplete spinal cord injury is limited by the filling and the diastolic volume. And the relevant aspect of this, that by doing the exercise, arm ergometer exercise, we can see that the conventional arm ergometer exercise is actually not efficient exercise that helped the patient to elicit a central adaptation among incomplete spinal cord injury. Further study actually should encourage understanding using functional electrical stimulation or using a large muscle mass, and help us to understand how the provision of early different mode of exercise help these patients to improve the diastolic performance. Thank you so much.
Thank you very much, Dr. Munira. Now we come to our last talk. It will be a privilege to introduce Dr. Mohammed Tahir Silarabi for this. Dr. Mohammed Tahir is a consultant in rehabilitation, originally from Nancy University in France, and they have been in Saudi Arabia serving in multiple places over the last 20 years, one of which was the Prince Sultan Humanitarian City as the chief of rehabilitation, and currently he is the medical director of IFA Center. Dr. Mohammed will be talking to us about stroke in young adults with a look at risk factors. Please.
It's this one. Yes. Good morning, everybody. Thank you for attending this session. I would like to talk about ischemic and non-ischemic stroke in young adults. We will concentrate on the risk factors and outcomes in developing countries. The problem, as you probably know it, there is a lack of data in developing countries. That's why we decided, since we received a lot of new patients, young patients having stroke, we decided to make a study, and this study will conclude with some recommendations which are important for the public health. As everybody knows, the stroke is a common neurological disorder increasing worldwide, with 15 million strokes and 5.8 million stroke-related deaths per year. It's a huge number. Most incident cases of stroke are ischemic. Yeah, the ischemic strokes represent around 87%, and the hemorrhagic stroke, which are divided by two, you have intracerebral hemorrhage and subarachnoid hemorrhage. Intracerebral represents 10%, and subarachnoid hemorrhage represents 3%. Stroke in young adults is more heterogeneous than stroke in older persons. The problem is the underlying risk factors. We have a lack of information about these risk factors in young adults. Despite this increasing number of young stroke patients, the risk factors of stroke remain unknown in the one-third of the patients. It's a huge proportion. We know that when we have the risk factors, we can prevent the stroke, because we have to treat aggressively these risk factors, and this is why we decided to have this study. And the risk factors, as you know, the most common is the hypertension, hyperlipidemia, obesity, and diabetes. And if you discover these risk factors and you treat them, you will prevent the stroke in this young population. Materials and methods, we have in Sultan bin Abdulaziz Military City, we had a stroke program. This stroke program is very important because we have stroke unit. As you know, the patients treated in stroke unit are really more successful than in general units, because the staff is trained and they are more specialized in taking care of these patients. The program in this unit is patient-centered, coordinated and integrated services. Really, it's very important to have a team which is trained, very well trained in the stroke program. The risk factors, we tried to discover among this population that we took during 4 years. The study was trying to find some solutions for these people who are having unknown risk factors. We started the study from 2015 until 2019. We had a good number of patients. It was 710 patients. As you know, in the younger people who had stroke, the stroke, when it is treated, we get very good results comparatively when we compare it to the older people. That's why it was important to have this study and to develop a politics for the future in developing countries. This is a retrospective, as I said, from January 2015 to December 2019. The inclusion criteria for this study was that the patient has to have a stroke at least for 6 months. Then it is implemented for both genders, female and male, and the population that we took in consideration was from 18 years old to 55 years old. Exclusion criteria, we don't take patients who have not stroke. We have, for example, congenital disease, malignancy, neurological diseases, and psychiatric illnesses were excluded. all the involved cases are classified according to the ICD-10. Ischemic stroke is an episode of neurological dysfunction caused by focal cerebral, spinal, or retinal infarction. Intracerebral hemorrhage is a focal collection of blood within the brain, parenchyma, or the ventricular system that is not caused by trauma. The data collection, we used the case report form for that, and we took the informations, the data regarding the age, gender, and the residence area, clinical assessment, history of disease such as ischemic, non-ischemic, hypertension, hyperlipidemia, cardiac disease, and family history of hypertension and diabetes. Smoking history was collected. In the cardiac conditions, we have all these, the major risk source and the minor risk sources. You can read them. It's common in general. We found them, most of these syndromes, of these problems, were found in our study. We used also laboratory data with the research of hemoglobin, white blood cells, platelets, blood sugar, HbA1c, lipid profile, including total cholesterol, low density lipoprotein, high density lipoprotein, and in addition to urea, creatinine, and sodium and potassium. Sorry. Functional independence measure was used, as everybody knows. It is very important because you have to evaluate the patient in the beginning and at the end of the treatment to make sure that you have numbers to evaluate the patient. It's common and everybody knows about functional independence measure. The results, characteristics of the study population. The study includes, as I said, 710 patients, young stroke patients from 18 to 55, who fulfill the criteria of stroke and have been assessed for risk factors. Out of the total number, 511 were described as ischemic type and 199 as non-ischemic. I will show you this graph. It is really very, very clear that, where is the, yeah, you have male adult, you have according to the age, okay, the youngest from 31 to 40, from 41 to 50, from 51 to 55. You have mainly ischemic male is the most important, then ischemic female. Then non-ischemic came after. This is really representing most of the studies are in the same way, I think, describe the same thing according to the this graph. The ischemic stroke is in male is more important, is very important according to the female, and for this we have mainly hypertension, which is the risk factor, dyslipidemia, blood sugar. All these are very important. We discovered in those who are not known to have risk factors, we discovered that they had several risk factors which could be treated before developing a stroke. And the problem when the young people have a stroke, they have a disability for longer time because they are young. And it's really very important to prevent this stroke, because if we prevent it, we will not have this obligation to follow up the patient during years and years. And the stroke in general has an impact on the quality of life. The large cohort study over the long collected young stroke patients from wide areas in the kingdom, being a tertiary rehabilitation center. In developing countries, mean age of the first stroke is 63 compared to 69 in the US and 70 in England, which indicates that developing countries are hosting more young population with stroke. Although we are presenting non-acute stroke patients, this study had brought up a better understanding for patients suffering from ischemic stroke versus non-ischemic stroke at the young age group from 18 to 55 years. Prevalence of stroke, regardless of etiology, demonstrates increase with age, although males are 3 times more than females. For ischemic stroke in different age groups, which is an observation reported from Helsinki Young Stroke Registry for age-specific stroke. This could be related to the low prevalence of vascular changes observed in females based on their hormonal factors, in addition to the fact that males are prone to large vessel atherosclerosis at this age. Non-ischemic stroke was more predominant among males, especially below 40, mainly in the form of subarachnoid and cerebral hemorrhage. This is the same observation as found in an interstroke study that has investigated different risk factors for stroke involving 32 countries, including data from the Middle East. As males are more prone to trauma than females, we can see a higher incidence of hypertension among them, which later contribute to intracerebral and subarachnoid hemorrhage. Other explanations, like a higher incidence of arteriovenous malformation prevalence in males when compared with females. Hypertension is the most frequent risk factor in both ischemic and non-ischemic patients. The univariate and age-gender adjusted odds ratio did not demonstrate this risk factor to be of significant value that is similar to the findings from a retrospective hospital-based study from Iran. This could result from antihypertensive drug therapy as well as lifestyle modification changes among young adults. That's the explanation of this. A meta-analysis study conducted by Lu and a collaborator showed that when the systolic and diastolic blood pressure was reduced by antihypertensive therapy, the incidence of stroke declined by 41%. It's very important to stress the patient to take medications, to take his antihypertensive. In the current study, 2 minutes, sorry, I will go quickly. In the current study, hyperlipidemia is strongly associated with an ischemic stroke. The strong study revealed that greater lipoprotein cholesterol level confers a high risk of ischemic stroke. High triglyceride and low HDL levels observed in patients suffering from diabetes have a more than 2 times higher incidence of ischemic stroke. I will go quickly. The studies have shown that diabetes among young adults is associated with a higher risk of stroke, and it's disturbing that the incidence of diabetes in young adults is increasing. This would stress the fact that glycemic control of patients with diabetes carries an important role of preventing ischemic stroke. The other risk factor is cardiovascular. As I showed, cardiovascular, you have minor and major factors. Generally, it is especially in atherosclerotic changes. We saw them in most of the patients with the ischemic stroke with cardiovascular condition. A total of 5.6% of the studied cohort were found to have recurrent stroke. Obesity was not observed among stroked patients regardless of the type of stroke. This is inconsistent with the Northern Manhattan study, which has concluded that abdominal obesity is an independent risk factor for ischemic stroke in all ethnic groups where BMI was no value on such findings. In conclusion, the study concludes that that risk factors such as hypertension, hyperlipidemia, cardiac disease, and diabetes were more associated with ischemic stroke rather than non-ischemic stroke. And this calls for a prevention plan at the national level with a focus on various lifestyle factors, proper rehabilitation process for young adults to prevent stroke, and the recommendations to help diagnose stroke at a young age and improve care. We are also looking forward to the implementation of the population-based study of stroke in each region and making ties with the regional and national stroke registries here in Saudi Arabia. The identification of risk factors for young stroke incidence is a step towards improving health in young adults. Various organizations have disseminated awareness and encouraged research in this area. However, a more comprehensive study with larger numbers and well-defined risk factors is needed before such programs can be established. These types of studies could lead to better treatment and management, potentially reducing the impact and burden of ischemic stroke in the highly productive age group. Thank you very much.
Thank you very much. We have, I'd like to thank all speakers for a wonderful presentation and sticking to the time. We will have around 8 to 10 minutes for questions and answers. If you have a question, we have a microphone here for the speakers to answer. Let me start by asking Dr. Muhammad Mheza about can this SMA diagnosed by intrauterine, say, sampling of the fluid or placenta types, so that this can, and if the abortion will be indicated at this level or not?
You asked the most difficult question. diagnosis. For diagnosis, the answer is yes, you can do antenatal diagnosis. In fact, it has been done, it's here even before the therapies were available to advise for termination of pregnancy. As for termination, you need a scholar and ethicist to answer this question because it is an area of debate now. With these therapies, is it legal to terminate the pregnancy or not? So this is a very complex question. I really cannot answer it carefully because it's more than a patient; it's also a family obligations, etc. So I'm sorry, I cannot answer this question.
Yeah, please go ahead.
Just a question, practical. If you have a child 10 or so with SMA type 3, would you start Ziplam or would you go with Nusinersen? And what would be your criteria for choosing either? And do you foresee the future where our SMA patient will come to the clinic with a bag of medications like the diabetes and hypertension? And given that there's a lot of ethical dilemmas that we have to deal with in management of such patients.
Another difficult question, but I will try. Well, for SMA type 3, I think there are a few points that you need that will help decide whether to go for intrathecal nusinersen or oral risdiplam. We know in older patients the bioavailability or the level of the orally given medication declines a little bit. So there's a question about whether the intrathecal is better. If a patient has significant scoliosis, it's difficult to administer the intrathecal, of course, we'll go for oral. If the patient is easy to take this medication daily basis orally, I would do it. Personally, I would tend to use oral in older patients whom the value is not really that huge, and therefore, if you look at the cost-benefit, it probably would favor risdiplam than intrathecal. The effect, because we know more about nusinersen, we think nusinersen is slightly superior to risdiplam. So, again, it depends on the patient, the family situation, whether they can come for this intermittent injections or not. Compliance with standard of care, all of these play a role in which therapy. So I answered with a few questions, but I tried.
All right, thank you very much. Dr. Amna, I have one question. With the now more advanced in genomics, could we develop a genomic panel that can early diagnose high-risk patients for epileptic encephalopathies, as the majority in your study was not really identified as related to some genetic specific disease?
There's actually a panel for epilepsy patient, and we tend to go for the panel usually, where particularly epileptic encephalopathies, for example, in our center we have to send genetic testing. We used to go with the epilepsy panel, but more recently we have been thinking to just go with whole exome sequencing, given that we have 30% of unidentified patient, and the price has also decreased dramatically, where both are almost similar pricing in terms. So, and the yield is, we think, is better. I believe we need to do more in terms of maybe going for whole genome sequencing for those patients who fail to identify a genetic pathogenic mutation. I believe that at the end of the day, with those catastrophic, it all goes back to genetics. And if we look more closer in research labs where we don't have in the country, maybe the yield will be much higher than what we had. I did not present the studies on the genetic factors, but this is, we have the data, we are analyzing them, and we'll soon know more. Actually, we went back and studied, we included the patient from 2010 to 2022, January, and we have 280 patients with epileptic encephalopathies in our center only. So the burden is huge, and I guess we are also missing, and maybe there are more genetic factors that we have not identified that needs more work.
Thank you very much. Well, to be fair, I want to ask every speaker a question. Dr. Munira, very interesting, because I'm a thoracic surgeon, so I'm very much interested in cerebrovascular. Do you believe that patients who develop incomplete spinal cord can prevent this weakness or cardiac weakness by early exercise, even to the upper extremities? Or it is just a sequence that will occur regardless of rehabilitation early?
Okay, nice question, really. If we are talking about non-pharmaceutical agents in intervening these patients, I do believe any kind of volume loading, kind of exercise, not pressure loading, would help these patients at early stage, especially if we involve large muscle mass and functional electrical stimulation that help in the pumping capacity of the muscle, that actually will show an impact, because based on the previous studies on other patients, not incomplete spinal cord injury, but in general, when they study the effect of large muscle mass and functional electrical stimulation, it does show that these actually factors, if we incorporate these in exercise, that will induce a volume loading, and that could actually has an impact on the diastolic performance.
I would like to lastly ask Dr. Muhammad, it's quite interesting that if we aim to reduce the average age of risk of stroke by 5 or 10 years, it will have a great impact. So this can be really initiate a national, in the presence of what we call value in health and quality of life, that the Vision 2030 is now doing. Do we believe that we can, as much as we aim to, say, extend the average life expectancy, we can actually delay the incidence or the peak incidence of stroke?
Yes, you are right. You know, the main problem, there is lack of data, you know, and not only that, lack of data means that you cannot intervene in the public health. Public health, if you expect to have an impact, a positive impact on the population, you have to have a data, and you have to instruct all the care providers about the early intervention, about treating aggressively the risk factors, because this is the main problem. Some people have hypertension, they don't know that they have hypertension until they develop the stroke. Some patients have diabetes and they don't know that they are diabetic, and finally they develop stroke. At that time, when we investigate, we find that they have so many problems which are ignored. This is really important to stress everybody, to have investigations, to see his physician regularly. This is really very important, because without that, we'll continue to face the many patients having stroke, and unfortunately, even young people now, we receive more young people with stroke since a few years.
But wouldn't it be strange that obesity and smoking were not among the risk factors in your study?
No, this is only in our study, because we have 710 patients. Among these patients, we didn't find that obesity was really important. One, and the diabetes is. We know that most of them they take medications for diabetes. That's why it is not reflected in our study.
And smoking?
Smoking, Because there are many ladies within this population. Ladies are non-smoker, less smoker than male. That's why maybe it is not reflected in the study.
Okay, thank you very much. At the end, I would like to thank our four speakers for this brilliant session, and thank all the attendants for being with us into that, and I hope it was a very informative session. So we have now a break and we'll continue this afternoon. Thank you very much all.
Our next speaker, الدكتورة هنادي مطر الحاثي. حياك الله دكتورة هنادي.
Controlled by brain areas such as cerebellum, basal ganglia, and frontal lobes that collectively interact to exert control over executive functions and intentionality of movements. Motor actions implicitly involve various integrated cognitive functions that allow successful motor performance. Statement of research problem. Previous studies found that motor impairment is related to mild cognitive impairment in some neurological disease such as Alzheimer's disease and stroke. However, to our best knowledge, there has been no study addressing this association among patients with multiple sclerosis. The first aim of this study is to investigate the association between cognitive impairment and muscle weakness, motor coordination, poor balance, gait abnormality, and high risk of fall in patients with multiple sclerosis. The second aim, examine if any of these variables, motor variables, can be adopted as the best indicator of cognitive impairment in patients with multiple sclerosis. Significance of this study, understanding the association or relationship between motor and cognitive impairment is crucial to design appropriate treatment plans that consider the patient's unique symptom profile and provide holistic care relevant to the success of physical therapy. Now let's move to the method section. Study design is a cross-sectional study. Participants were a total of 70 patients with multiple sclerosis, and the sample size was estimated based on the G-power analysis program. The inclusion criteria were age between 18 to 65 years of both genders, and confirmed diagnosis of multiple sclerosis regardless the type, patient able to read and write, and able to walk with or without assistive devices. While inclusion criteria were patients with communication difficulties, severe muscle weakness, and spasticity based on modified Ashworth scale and based on manual muscle testing. visual and hearing impairments, individuals with other neurological diseases rather than multiple sclerosis, and individuals with a history of psychiatric illnesses. Outcome measures I used for cognitive assessment, Montreal Cognitive Assessment Scale, MOCA scale, Arabic version. For muscle strength, I used hand grip dynamometer to assess the hand grip strength, and I used handheld dynamometer to assess the knee extension strength. Motor coordination, I used timed alternate heel to knee test for lower limb coordination, and timed rapid alternating movement for the upper extremity coordination. I used Tennessee Performance Oriented Mobility Assessment or POMA scale to assess balance, gait, and risk of fall. Ethical consideration, ethical approvals were obtained from the Health Sciences Institutional Review Board at King's University and Sultan bin Abdulaziz Humanitarian City, Riyadh. A consent form was filled and signed by the participants. Examiner completed training and certification program, as well as permission was taken to administer and score MOCA scale. Data was collected by trained physical therapists, and screening sheet was used for eligibility and to gather participant demographic data. For data management and analysis, all statistical analysis was performed by using SPSS. Participant characteristics were presented by descriptive analysis. Correlation coefficient test was used to assess the correlation between MOCA and motor variables. And before I used correlation coefficient test, I used normality test. Correlation coefficient test was used to assess the correlation between MOCA domains and all motor variables. Motor variables that significantly correlated with MOCA were used in a multiple linear regression. Finally, all data were expressed as mean and standard deviation. P-value was less than 0.05 with 95% confidence interval. Now let's move to the result section. As you see, this table highlights the subjects and demographic data. As we see here, 88.6% of the sample of the participants were right-handed, 78.6% were female, 92.9% had relapse-remitting multiple sclerosis. The mean of the age at onset of symptoms was 26 years. The mean of the disease duration was 10 years. Regarding body mass index, about half of the participants have normal body mass index, and about 2/3 of the participants held bachelor degree. As you see, this chart highlights the percentages of MOCA levels. As we see here, 67% had mild cognitive impairment, 27.1% have no cognitive impairment, and 5.7% have moderate cognitive impairment, while the patients or participants who had severe cognitive impairment were excluded from the study. Also, you can see this chart. As we see here, percentages of MOCA domains among the participants. Memory, as you see here, the memory was the most affected domain, about 84.3%, followed by executive function and visual spatial skills, 74 and 71.4% respectively. The lowest affected domain was the language, 26%. Now let's see this table illustrating a correlation between MOCA and motor variables. As we see here, MOCA has no association or no correlation with muscle strength, either hand grip or knee extension strength, while there is a correlation between MOCA score, total score, and supination pronation test, which now we have a negative or inverse moderate correlation between MOCA and incoordination of upper extremity. Also significant correlation between MOCA and heel-to-knee test. Regarding POMA or Tennessee scale, we have also significant moderate positive correlation with balance, gait, and risk of fall. Now let's see multiple linear regression. I will go through it quickly. Risk of fall, upper and lower limbs coordination variables were entered in the regression analysis as independent variables, and MOCA was entered as a dependent variable. Using stepwise method, the significance first model emerged with an R-square of 0.172. In model 2, a 22.7% of the variance in MOCA was predictable from the risk of fall and coordination of upper extremity. As you see this equation, statistical equation that describes the best fit of the regression line, which means a 1 unit increase in the total POMA score increased the MOOCA score by 0.147, which was significant. Also, a 1 unit increase in the supination pronation score decreased the MOOCA score by 0.539, which was also significant. Now let's see this scatter plot of MOOCA on the risk of full and upper extremity incoordination. Now let's move to the discussion section. The analysis showed that cognitive impairment is significantly associated with motor incoordination of upper and lower extremities, poor balance, gait abnormalities, and high risk of fall. Also, the results show that the mean total MOOCA score indicated mild cognitive impairment, and in about 2/3 of patients with cognitive impairment, which is consistent with other studies or with the previous studies. We found that memory, visual spatial skills, executive functions, attention, and language were affected domains among patients who had cognitive impairment, which is also in the line with previous studies. Similar to other studies, there was no correlation between hand grip strength and MOOCA score, but there was a significant correlation between hand grip strength and the language and attention domains. The study found no correlation between lower extremity strength and cognitive impairment. In contrast with the previous study, found a positive no correlation between cognitive performance and knee extension strength. In 2009, Valentino et al. Reported that relapse-remitting multiple sclerosis patients with cerebellar symptoms exhibit poor performance on attention and verbal fluency tests than patients without cerebellar symptoms, which is in the line with our result. Our findings showed that balance component of POMA has shown a significant moderate correlation with cognitive impairment. In 2017, ورشة et al. Found that working memory, attention, and executive functions were associated with postural control in the upright position with an unstable platform among MS patients. The gait component of POMA scale was significantly correlated with cognitive impairment, consistent with previous studies demonstrating a significant association between gait abnormalities and cognitive decline in patients with multiple sclerosis. It is interesting to note that no study used the gait component of POMA scale for this assessment of gait and its correlation with cognition in MS individuals. The findings of this study show that risk of fall has a significant correlation with a cognitive impairment and predicted cognitive impairment in patients with multiple sclerosis. Fall frequency has been shown to be significantly correlated with general intelligence, processing speed, and executive functioning, while verbal memory was found to be a significant predictor of falls in patients with multiple sclerosis. This was in a study in 2012 by Oreo et al. Limitations and implications. The sample size is relatively small, and further studies are required with a larger sample size to reduce the robustness of linear regression. Most of the participants had relapse-remitting multiple sclerosis, and future studies should involve all MS subtypes. The gait component of POMA scale used in this study is based on the examiner's observations. Therefore, future studies using advanced gait analysis systems are now needed to better detect temporal and visuospatial parameters. This brings me to the end of my presentation to conclude that cognitive impairment is significantly associated with motor incoordination, poor balance, gait abnormalities, and increased risk of fall. More specifically, the risk of fall and upper extremity incoordination were the best indicators of cognitive impairment in patients with multiple sclerosis. Thus, motor assessment can provide physical therapists with clues about the presence of cognitive impairment in patients with multiple sclerosis. In addition, incorporating coordination and balance training into the rehabilitation program may enhance the patient's cognitive functions for patients with multiple sclerosis, although this requires empirical testing. Finally, thank you for your listening, and I would like to thank King Salman Center for Disability Research and the organizers of this amazing conference. Also, I would like to thank Sultan bin Abdulaziz Humanitarian City and King Saud University and the College of Applied Medical Sciences. Also, I would like to thank Mu'in Volunteer Health Team and SAD Association for Multiple Sclerosis Patients. Also, I would like to thank all MS patients or multiple sclerosis patients who volunteered and participated in this study. Thank you for your listening.
And we would like to thank you for the focus and concise study. شكرا لك، الله يعطيك العافية. متحدثنا الثالث. أول شيء شكرا للمتحدثين الأول والثاني على المحافظة على الوقت. بنحفظ وقت أطول للأسئلة. أنا لاحظ الآن في كومنتس وكأن الشهية عالية الآن للأسئلة. أؤكد على جميع الحضور على كتابة وتوثيق الاستفسارات. المواضيع زي ما تشوفون ولله الحمد متنوعة وتخصنا كلنا كمختصين، وبإذن الله نخرج بتوصيات تفيد الوطن، تفيد الممارس، وتفيد المنظومات الصحية اللي تقدم الخدمات الصحية. شكرا لكما. الآن محاضرنا الثالث الدكتورة ريم بنت عبد الرحمن البشر. حياك الله دكتورة ريم. دكتورة ريم حاصلة على الدكتوراه في العلاج الطبيعي، تعمل دكتورة في كلية الصحة وعلوم التأهيل في جامعة الأميرة نورة، ومديرة برنامج الدكتور العلاج الطبيعي في جامعة الأميرة نورة. حياك الله يا دكتورة.
Good evening, everyone. So today I'm presenting about the association between early motor development at 12 months and preschool age outcomes, either motor and gait outcomes in children born very preterm. So this is the outline of our presentation today, going through the background of preterm birth and ending with the recommendation to implementing motor detection in Saudi Arabia. So preterm birth, around 10% of infants born worldwide actually born preterm. And this is the classification, so any infants born at less than 28 weeks gestation, they are extremely preterm. Then very preterm, those less than 32 weeks gestation, and moderate to late is 32 to 36. So preterm birth, the good thing is that the survival rate of preterm infants actually increased markedly over the last 2 decades. However, the subsequent motor environment is still high. The earlier the infant born, the higher the risk for these motor environments that persists throughout the life of those children until adulthood. So for instance, we can see here an example for the long-term motor outcomes. So in term children, those born at around 40 weeks gestation, the risk for motor environment, here we mean mild to moderate, it's around 7% of those children, and CB is as low as 0.02. However, when we take a look at the sample of those born preterm, the risk for mild to moderate motor environment is as high as 50%, and the cerebral palsy is around 15%. So what about gait? So those children born very preterm, for example, walk 2 months later, based on an earlier research done by me and the group, later than their term-born peers, and when they start walking around the school age, they still walking with wide base of support and shorter steps when we challenge their walking. We'll talk about challenging situation later on. And when we take subgroups of those children with risk for motor environment, this challenge actually gets increased. So why we need to identify those children early? So infants at risk for motor environment actually end up having poor neurodevelopmental outcomes based on evidence. However, if we give early intervention early on, we can improve these outcomes. To set this outline, we need to detect those children very early to hopefully we need to detect them around the NICU time. There's many assessment tools now to help to do this. And today we will talk about 1 year of age, because also in Saudi Arabia, most of those children usually not seen during the first year. By around 1 year, they usually seen in some hospitals. So the aim of this study was to examine the association between early motor development at 12 months and the gait and motor outcomes at 4 to 5 years in those children before their transition to school. So the method, this is a longitudinal cohort study done with the Victorian Infant Brain Studies in Australia, Victoria, and infants recruited at birth, who were born at less than 30 weeks gestation. We started with 149 infants. We saw these children at 2 time points. Here we can see the protocol for this follow-up. So at 12 months, the assessment component were 2. So we had the Alberta Infant Motor Scale, We'll talk about it now. And also we take indication from the parents if they walking or not, and confirmed by the therapist at that time point. So all assessment done by physiotherapist. So the Alberta, just a brief look at the Alberta Infant Motor Scale. It's an easy, quick assessment tool. Test gross motor skills for infant from birth up to 18 months. In most common positions, it's done in 20 minutes. It's feasible. It's not expensive. It can easily be implemented everywhere, and it's very common assessment tool used worldwide for infant born preterm. So, and with good and reliability and validity. So at 4 to 5 years of age, neurodevelopmental assessment include first the movement assessment battery for children, the second edition, movement ABC. It's the gold standard now to detect non-CB motor environment. And we were interested in the total scores, sub-scores, and also in the motor environment identified by this assessment, which is the risk at those who score less than 16th percentile. For gait assessment, the gait assessed by physiotherapist also, and it used the gait right system that we see here. It's electronic carpet with attached to a laptop with the system implemented on it. And we were interested in the spatiotemporal characteristics, which is the time and speed and distance characteristics, and it's the variability of these variables. So 4 walking conditions were assessed, starting from preferred walking, where the child walk freely at their selected speed, then go to cognitive dual task, where the child walk while providing as many items within a certain category, like for example, name colors as much as you can, and scored. Then motor dual task, where the child walk on balancing 4 table tennis balls on a plate. And we take numbers of the dropped balls and to assess performance. And here the tandem walk, where the child walk on the line. 6 trials for each walking conditions for reliability. So why we pick these 4 conditions? Why it's important? It's part of the everyday task the child can do. Here you can see my daughter practicing all these 4 conditions in a trip to the park. So it's an important component for those children, especially then when they transfer to school. So at this 2 time point, at 12 months, here we can see that 138 had the AIMS assessment, and 4 to 5 years we had around 122 children with motor, gait, or both of them. So we end up with 118 participants, and we excluded cerebral palsy because the known and well-investigated impact of cerebral palsy on gait and motor outcomes. Here we can see the characteristics of our participants, and we can see, to highlight that the AIMS cut point, which is 5th percentile, we didn't use it in this study because we know it sometimes detects some children who end up having normal development. And here the movement ABC 6th percentile. So for the outcome, we found that children with better AIMS total score actually end up having better balance performance that we see as higher scores in balance scales in the movement ABC, and also the narrower base of support in tandem walking, which tests balance for those children. Also, a better AIMS total score associated with the lower rates of motor impairment detected by the movement ABC. And there was minimal evidence of association with other outcomes. All this association were tested using linear regression and clustering for multiple birth to avoid the impact of multiple birth in the data. So also independent walking, the ability to independently walk at 12 months was associated with better balance skills and lower rates of motor impairment. So it's good, can be good indicators of later rates of motor impairment, and also associated with faster speed and lower double support time. So they were walking faster in the dual tasking, motor dual task walk. Similarly, there is minimal evidence of association with other outcomes. So the key message here is for clinical, the aims at walking independently at 12 months can be a good indicator of motor environment and balance at preschool age in children born very preterm. And similarly, the aims may be helpful to identify infants at high risk of motor and balance environment at preschool age to facilitate earlier intervention and timely referral within the high risk population, because we know that preterm it's hard to refer all those preterm infants to intervention, so we can select those who will benefit more. And the good thing for a community like parents, because always parents concerned about the age of children walking, so it's the ability to walk at 12 months, not necessarily related to later gait development at school age. Just I try to put suggestion to promoting early identification of infants at risk for motor environment in Saudi Arabia. So what we can do at this stage is identify barriers to clinicians to feeling confident, more confident to make decisions about early diagnosis of CB and motor development, other motor environment or developmental environment, conduct research and develop local data, as we're missing this part here unfortunately, and give more training and awareness about this topic and the importance of it. And also to incorporate early detection in teaching of BT, OT and medical students as a crucial part of this teaching process. And also to finally to involve stakeholder and partnerships to support implementing. Finally, we're working now to have more the greatest, if anyone know like about general movement assessment and other early movement detection at NICU and the first year of age. If anyone interested, we're trying to collect who interested, so because we want to conduct the first one in Saudi Arabia inshallah by around next year inshallah. So if anyone interested, it's just a small survey indicating your name and contact, so you can be contacted with once we have it ready. And thank you for your time and for listening. Thank you so much.
شكرا جزيلا يعطيك العافيه دكتوره ويعطيك العافيه. الان ننتقل الى المحاضر الرابع. معنا الدكتوره ايناس محمد شاهين، استشاري ورئيس قسم الطب الطبيعي واعاده التاهيل بمدينه الامير سلطان للخدمات الانسانيه، استاذ الطب الطبيعي والتاهيل في جامعه الاسكندريه في مصر، وخبره في مجال الطب الطبيعي والتاهيل لما يزيد عن 25 عام. ستحدثنا مشكورة عن الدكتور
to be twofold by 2050 to reach 3.6 million people. Of course, this data is from United States. And it is expected in the Saudi Arabia that by development and the changes in the social characteristics of the kingdom, that it changes in the age, gender prevalence, as well as causes and types of the amputation will happen. For example, we have a higher incidence of road traffic accidents and the prevalence of trauma with subsequent higher traumatic amputation rate. Also, the incidence of peripheral vascular diseases and diabetes in Saudi Arabia is also increasing. That will put more burden over lower or mostly lower limb amputation more than upper, of course. These changes create greater demand for changes in the way of providing effective education, preventive measures, and management services for those patients. The exact data on incidence of amputation is important for improvements in preventive health care. However, the published data are not sufficient, underlining the necessity for studies on changes of amputation risk factors, characteristics, and rates over time. Relatively few researches for amputation are available in Kingdom of Saudi Arabia compared to other countries, and the only research that we found was published study in 1993, which was a retrospective study collecting amputee patients in a rehab center in the period from 1977 till 1990. The primary reason is the lack of national registry of amputations in Saudi Arabia and the limited such published reports, which still represent a significant challenge for healthcare policymakers in the country for the, as I said, preventive and management plan for those patients. Although the prevalence of disability in general in Saudi Arabia is considerably higher than of other high-income countries based on the Saudi National Disability Registry. So this study was designed to bridge some of these gaps in the literature. I was honored to share in this study, me as a principal investigator with my colleague Dr. Mohammed Salarabi in Physical Medicine and Rehab Department, Mr. Abdullah Elzir from Prosthetic Departments, Mr. Mustafa Bukhamsin from as a occupational therapist in Rehab Department, Khalid bin Zar'a from Pediatric Department, and Ms. Iram Saba from Research and Scientific Center. The objectives of the study, the primary objective was to determine the etiology and the clinical characteristics of amputation of those patients who attended the outpatient limb loss clinic in Sultan bin Abdulaziz Humanitarian City from the period of June 2010 to June 2020. The secondary objective was to determine the risk factors and rehabilitation functional outcomes for those patients, of course, for those patients who were admitted as inpatient to have a post-prosthetic rehab program to use prosthesis. The significance of the study is to provide the appropriate prosthetics and rehabilitation services for amputee patients and to establish a suitable plans to reduce the incidence of amputation and re-amputation by identification and reduction of risk factors for both events, either primary amputation or re-amputation. As I mentioned, it was a retrospective chart review hospital-based study. It was carried over all patients with amputation who visited our outpatient limb loss clinic from 20 to 22 June, the month was June. Of course, it was in the city itself. Our inclusion criteria included all those patients who visited the clinic, and we haven't have any exclusion criteria since it is a retrospective study reviewing the patient's records. The collected data from medical records include demographic variables for the cohort distribution, presence of comorbidities, of course, amputation, its site, laterality, level, incidence of re-amputation, and risk factors of those patients. As I said, for those patients who were admitted for rehab program, we collected the data for pre and post-prosthetic functional impairment measurement score at admission and discharge from the inpatient rehab. And informed consent wasn't actually taken because it is a retrospective study, but we got the Institutional Review Board approval for the study. We collected 1,409 patient data. Most of them were, as expected, the males, 75.6%, and 24.4% were females. The age ranged between 1 year and 96 years, with mean age of 45 years in males and 36 years in females. Saudi population constitute, of course, most of the population, being 86.9%. The number was 1,224, and non-Saudi were 13.1%. The number was 185. Although we are serving actually Saudi and non-Saudi patients. Central region of Saudi Arabia constitute the majority of recruited cases, 60.3%, Western region 17.7%, and Southern region 11.4%. Vascular etiology constitute the majority of the causes, 42.4%, traumatic 36.9%, amputations, and congenital amputations constitute 14% of the cases. Duration of amputation ranged between less than to equal 5 years. It was 40.4%, and ranging between 6 to 10 years, 29.7%. The most prevalent comorbidity was diabetes, 40%, followed by hypertension, 26.3%. This table summarizes the findings. Regarding level of amputation with the etiology, vascular diseases constitute the highest, as I said, percent of etiologists, but the highest was transtibial amputation in the vascular causes, followed by the transfemoral amputation. So a lower level of amputation is expected in vascular etiology. While trauma, the transfemoral amputation, a higher level, constitute the majority of cases more than the transtibial amputation. Transradial amputation constitute the majority of congenital cases, partial hand, followed by the partial hand, then the transfemoral amputation. This is the congenital amputations. Trauma-related amputations were the highest, 60.9% in the age group of 21 to 30 years, and the lowest in people over 70 years. So vascular diseases is a majority, but when we correlate the etiology to the age, in younger population, the trauma is prevalent than vascular diseases. While vascular amputation were highest, almost 89.5% in the age group more than or equal 70 years, and the least in the age group of 1 to 10 years. At time of presentation to the clinic, congenital amputation was highest in the age group of 1, actually 0 represent less than 1, to 10 years, and the least in the age group of 51 to 60 years. Improvement in functional impairment measurement score was noticed that there is a significant difference between the admission and discharge scores for self-care, transfer, and locomotion subscales of the FEM score. While the total or the overall FEM score improved 6 months post-discharge compared to the score at admission. We have like a follow-up with the patient, and we can recruit the patient again for measurement of their FEM score. So this was a finding for those patients who were recruited, and of course all of these were collected from the hospital records. This is changes of the FEM score value between admission and discharge. Actually, analysis of major limb amputation in Saudi Arabia and comparing the results to similar studies conducted in other regions emphasize the difference in the pattern and identification of for amputation and suggest relevant preventive interventions. This study provides a picture of the peripheral, physical, and pathological distribution of amputation in the 5 main provinces of Saudi Arabia. Amputation incidence may differ from one country to another, or even within the same country regions, based on several factors that include degree of modernization, so the higher incidence of like road traffic accident, for example, accessibility of medical and surgical care for those patients who have diabetes and they are seeking care to save their limbs before amputation, and the living standards. Male predominance among amputees could be attributed to more severe peripheral artery diseases as expected, higher smoking rates, and greater susceptibility to road traffic accidents among men than their female counterparts. As a protective factor in females, estrogen could be considered as a reason for lowering the amputation-related vascular etiologies in females. The rising incidence of diabetes and vascular diseases is increasing lower limb amputation risk in Saudi Arabia. This necessitates the importance of primary and secondary preventive efforts like early detection, medical education, patient compliance, and reasonable glycemic control in those patients. Ischemia was the most common cause of amputation in non-diabetic people in the 3rd and the 4th decades of their life, which is identical to the reports from other developed and developing countries' studies. Although trauma was found to be a second leading cause of amputation, as in developed countries, of course, with the higher rates of road traffic accidents, but it was the most common reason for amputation in young population in their productive and active age group, which was between 20 and 40 years. This is consistent with the WHO reports signaling that road traffic accidents are among the top causes of death in those aged between 15 to 29 as the first few months after receiving their driving license. Among the strengths of this study, that it is conducted in a largest tertiary rehabilitation center in the country, which was able to represent amputees nationwide and covered all age populations. Amputees in these institutes, which Sultan bin Abdulaziz are subject to a multidisciplinary approach that allows for better clinical, physical, and mental management and assessment. However, among the weakness of this study is it is a retrospective study where we just recorded what happened in the city records, receiving a patient after 5 years almost. This would not provide data related to immediate amputation outcomes. However, we have actually patients who come to the city within the first, I will not say first year, but maybe first month of the injury. More data need to be published to assess better this country etiology, characteristic and risk factors of amputation in order to help the healthcare providers and the patients in the rehabilitation setting to plan and establish effective and timely reasonable service matching amputee needs. These are my references and thank you.
شكرا دكتور، الله يعطيك العافية. الآن مع آخر متحدث معنا الأخصائي أحمد بن زهران، حياك الله. الأخصائي أحمد هو أخصائي علاج وظيفي ومشرف التأهيل الكلينيكي لبرامج الناجين من الجلطات الدماغية في مدينة الأمير سلطان للخدمات الإنسانية، ومشرف برنامج علاج الوثمة الليمفاوية، لديه أكثر من 15 سنة خبرة في مجال التأهيل الطبي. حياك الله.
الله يحييك، شكرا.
نكون متقيدين في الوقت ونبدأ بإذن الله الأسئلة.
السلام عليكم. ما أدري إذا الصوت واضح. First of all, I would like to thank the organizational committee and the scientific committee for giving us this opportunity to be with you today in the 6th International Conference of Disability and Rehabilitation. Today, I'm going to just talk about the overview for our journey in Sultan bin Abdulaziz Humanitarian City regarding the patient-centered care and our rehabilitation model of care. So by last October, the city completed 20 years, so it was the 20th anniversary. And as per the vision and the mission that was provided by Rahmatullah alayhi Prince Sultan bin Abdulaziz Humanitarian City, we are all working in the city to just ensure that we provide the best practices for the patients and to ensure that what we are providing to the patient is based on evidence-based practices. That is not just the main concern. We just need to enhance also the services to be something related to the patient needs and what they care about and where they need to improve and how we can consider their values and their needs so it will be something reflecting to their goals. So from the vision that was placed to be the internationally recognized center of excellence in rehabilitation and related healthcare services, and also from the mission that we work starting the services in Sultan bin Abdulaziz City to help people to help themselves. Here it was like the umbrella that where we can go further and where we need to improve. And also always it can be considered in our services provided to the patient and also the stakeholders from different areas to help the people to help themselves. By the way, the city, we opened the new branch in Riyadh City, which is the Sultan City Medical Center. And we expand the rehabilitation programs that we have it. It was before as around 8 adult programs and 6 pediatric programs, and nowadays it's 10 adult programs and 10 pediatric programs serving the patient in different age groups. We have the child development centers that was providing a specific specialties for the patient from pediatric age groups, providing the psychiatry, early intervention, hippotherapy, pediatric neurology, other services for physical therapy, occupational therapy, and vocational rehabilitation. Rehabilitation model of care, always in the clinicians' practices, the concern about the patient. They provide the focus more just to deliver the care, but we should always also consider the patient as one of the team who's planning the service and how we can ensure that what we provide to the patient is something valuable to them. So as per the definition of the patient-centered model care, it seems that always when we consider the patient-centered in our plans, in our interventions, that will reflect something positive about their outcome measures. And also it will enhance the participation from the patients, from the family, and how we can achieve the goals in a limited length of stay for their admissions or within the time that they are taking therapy within OPD programs. So based on that, there was in the beginning of the journey for Sultan City, a study was done in 2009 to July 2010 to study the positive impact of patient-centered considerations in our interventions. And it was done for around 1,125 patients participate in this questionnaire and this survey, and to come up with the recommendation that where we can expand our services, where we can enhance the value-based practices to the patients. So it was mainly about 5 areas, 5 domains: patient and family involvement in plan of care, patient and family or caregiver education, patient satisfaction, patient privacy, and information sharing with patient and family. And here we gathered the data to ensure where we can improve our services. So from the outcome analysis and recommendation, we found that orienting the health system around the preferences and needs of the patient has the potential to improve the patient satisfaction with care as well as their clinical outcomes. To regularly and systematically review the data from outcomes the person served that is related to the goals achieved in their satisfaction with the service delivered. Also, 99 of our patients return in the transitional period, return to home community after their discharge, to identify the implement new tools, ways toward patient-centered care, culture, and philosophy. Also to do a campaign that enhance the education and empower staff with tools for delivering services with the patient-centered approach. The significant progress in creating a model of care, it places the patient and the family in the center of the service. And this is the core point that we need to focus on. We have a lot of services done from interdisciplinary team, medical, nursing, rehab, PNOs. That's why we need to focus on engaging the family and the patient in this service. So in this case, we are aiming to achieve the patient demands and needs in a proper way. Patient and family-centered model of care is a journey, not a destination, because we thought it's just a target that we need to reach to it, but it's not like that. It's something we need to enhance it. We need to keep study it in a continuous improvement plans. So based on that, we found that there is a lot of data, there is a lot of services provided, and always we are measuring things, but we need to make it systematic. We need to come up with things can be standardized. The first step was to ensure that we have something to measure it. We cannot improve it if we don't have something to measure our service we provide to the patient, and to have a performance measurement using the data that we have it, also to get some feedback from stakeholders, starting from the patient, the fund, and the companies that are supporting the patient, and the referral resources. Having specific targets which can help to meet or get the target whenever we are having expectation to benchmark our services. Also to do our best to exceed this benchmarking to come with something in excellence level. So it came up with a lot of workshop to draft where we can start and from where we can focus. It came to the, first of all, you have the data. You need to collect it, you need to filter what you need, what you have, an effective data for that. Then you need to start to measure these data to know if it's really gonna reflect something positive and there is some gaps and there's some area of improvement. From there you can put some solutions. There is a good part that we need to focus on, and we start to do that with the staff themselves. We should enhance that the staff, they know their role in this journey, where they can support the patient and the family. So each one of the discipline, he need to know his role in this journey. And the communication, education, it's very important part, because if you don't enhance the knowledge level of the stakeholders in general, the team, from patient, family, and clinicians, about the importance of having the patient-centered care practices, that might make it difficult to go in a smooth way. That's why enhancement and doing more education sessions will enhance the practices. Then we should also analyze what we have done to check where we can improve, and also to do some root cause analysis if there is something have trend in a way that we are not seeing the effectiveness, or even if we have a positive impact, we need to study why this good result came. So from there we can utilize it as a all lesson learned for us. Patient safety, we cannot ignore it, because yes, we need to collaborate together, we need to ensure the patient-centered care, but patient safety is first always. So all the standards related to all the accreditation bodies always is implemented and considered. It came to the part that we know now which data we will measure and which area that we need to focus on, but we need to have the KPIs we need to have things to be like the main area that we need to measure it in a monthly basis, quarterly basis, and in a maybe yearly basis. There is a lot of KPIs or indicators we measure it internally, but this what we are reporting to ensure that all disciplines, they are aware about these indicators and performance level. Then we need to ensure there is a sharing for the performance against the goals and benchmark across the organization. We were thinking about to whom we have to share this information. So first of all, we need to share it with our patient. The clients themselves, they need to be aware about what's our target, what we are measuring in our services, and where we are as a performance level current practices. And also to the personnel themselves, to the staff, to the clinicians, to all the other disciplines team, and to the stakeholders. Sharing this information will give clear, transparent data for the current practices and also the performance. We thought about, first of all, to draft things. This, in the beginning, we are showing things. It could be as hard copies, posted in different areas, showing in each specialty. By the way, we are following CARF standards in a meaning that we have the specialty of the programs based on the CARF standards chapters. Like for amputee specialty program, we have a stroke rehabilitation program, brain injury, spinal cord, and OPD or CHERB, and pediatric. So in each specific program, we present the data that we have it in a yearly basis, starting by giving introduction about the service, how we are performing in these areas, and the patient will be aware about the services provided. To the staff, we keep always providing like brief updates in the monthly or the city staff forums to enhance their awareness about where we are and where we can improve. And always it's implemented in what we call it My City. It's an intranet platform available on all the computers in the city, so we can pass it to this data and we can see the areas and all the analysis done. So here it's like an example where they can find all the data related to this, and we can open any discussion with the staff who has any concern or he need to clarify anything related to that. In the beginning, everything was started as manual. We need to enter the data by ourselves. It's a learning experience. We have to enter it in a meaning that we use Excel. We have a lot of challenge in that because, you know, Excel and having backgrounds to aggregate all these data in one sheet. Sometimes if formula have a problem, that will affect all the data. But we keep enhancing always to protect things and to ensure that the data is collected until we reach with ICT, Information and Communication Technology Department, to enhance the data to come through dashboards from the system itself using our health information systems. Doing efforts from your side just to enhance the service for patient care, it's good, but you need also to listen to the patient. You need to have their perspective. So getting the patient satisfaction report is something important to link it together with each plans. So from here we start to do things also as to move some of the reports and to enhance some of the points additional to the patient feedback indicators. In this way we can study it together. So the idea of international professional patient care committee came up, and we start to study all the things related to the patient care, and all the indicators comes from the clinicians themselves or from the patient through the survey that happens and done for the patients. Here how we reporting and what the things that usually we study to ensure that each program, for example, if I'm covering the stroke program, there is other team, they are working in the spinal cord, so that's good to ensure always in a regular manner what's the area we need to enhance it further. And for sure, who knows about the quality and how we ensure the continuous improvement, we need to study it in a run chart. So in a regular manner, we can see where is the area that it really goes good, and if there is any trend or something affects the process, we need to study it further. Without ignoring the patient satisfaction, any complaint came from them, and also the feedback of the patients. And there is something we found it's very positive, that what we call it leadership rounds or safety rounds. It happens in a quarter basis that we move between the programs as the leaders to just interview the staff, interview the patient, get the feedback from them. Some of the things maybe the patient or the staff, they are not reporting in the channels that we are sending to them for surveys, but whenever we go by ourselves face to face and we discuss it with them, ensuring the safety culture, and we have this data to be just for something to improve. We get a lot of positive inputs from that. And also, if there is any concerns, it will be reported. And newly, we have implemented something they call it the tiered huddle, which is in every day we are having stand-up meeting. We discuss some of the things related to the patient care. Some of the concerns came from the patient themselves. We go from face to face until it reaches to the top management, to the CEO office, and we'll have the feedback within. If we start in 8 morning, by 11 a.m., we'll have the feedback from the top management about all the concerns that came. Some of the things it needs solutions for long term, but majority of things it will be solved immediately. We came to the point that we're measuring and receiving quantitative data on clinical quality performance, patient safety, patient safety and patient experience. This is a point of patient experience, staff engagement and satisfaction and experience, physician engagement, satisfaction and experience, also safety culture. And why safety culture? And it was something we spent a lot of time on it to enhance it further, because staff, clinician who is working with the patient, they need to feel by the safety, because this is something important to enhance reporting. If we don't report, if we don't have a safety culture to make continuous reporting for what happens with us in a daily basis or in whenever there's an incident that might affect the service. From here, we came that we need to make it in a domain, so clinical quality or safety, patient experience of care, and the staff and physician engagement satisfaction. Then we start to look for it in a different way, that patient, they are taking a service from multidisciplines, so that's why data has to be collected and to be studied in a multidisciplinary way also. And based on that, there is a top management order came that we need to start the department of patient experience. And we have now patient experience department, people experience department, to enhance both sides, the staff experience and the patient experience, having measures for both areas to enhance the service itself. And in the patient experience, they have developed 210 performance indicator. Not all of it is reported. It's a lot of indicator, some of it internal, but all it's needed to ensure the patient journey and patient experience in Sultan City is maintained, and always it will reflect something positive for their values. And it will be like classified in patient safety, clinical quality, patient experience, staff engagement. Patient safety culture survey, it always also provided for gathering all the data related to that, and we have a process to analyze it and come up with all solutions that it's needed. We have what we call it in Arabic, فاقد الشيء لا يعطيه. If the staff themselves, they are not having the safety culture, they are not having the chance to report, they are not having also the satisfaction studied in every time. That's why we cannot ensure that the patient, they will have the same experience. So considering the staff satisfaction, some indicators came to the people experience department, helps in that. And we came up to the point that we have to report all of these findings and what we have from the performance in our website, so that can be shared with the community. And in the website we can find patient satisfaction, access to equipment, average length of stay, readmission rates, and infection rates. Yes, I'm almost done. So for the bulletin board, this is what we share as what we said in the beginning in the programs. And patient and family shares their experience, feedback, and respective their words throughout the organization by having different committees even the patient advocacy committee. So we have a patient working with us to always give plans and also to share some of the strategic ideas. Person or patient-centered improvement begins with the voice of the customer and relies on their perception to identify priorities, derives improvement, and evaluate the results. Finally, this is what we are working, as what we said, it's not a destination, it's a journey. We need to continue, we need to measure it on a regular basis and to enhance it further. Always there's a focus groups done, community meetings, patient advisory committee, comments in patient satisfaction and experience survey, we are always studying that, and patient complaints always considered. By June 2021, the city got the patient or person-centered care accreditation from Braintree for the first time, first visit I mean, and it was with the golden level for a score of 95%, and that was like a conclusion for all the efforts was done in the previous years. The city is expanding now the services, either in the medical specialties, surgical center of excellence, specialized services in rehabilitation programs. We have to dig down deep and to check where we can improve further. Like we have what we call it the lymphedema, wound care management, and also post-cancer therapy, rehabilitation, hippotherapy. It's become more advanced, and we have the hippotherapy inside the city. We have Sultan bin Abdulaziz Specialized Center for Prosthetic Limb. It's a workshop at the level of international excellence level. Home health care, mobile clinics start to be shared with all the other cities from Saudi Arabia. Academic affairs and research center expand, and we start to think about how we can reflect what we are doing from efforts in a research center, in research activities. The same is implemented in Sultan City Medical Center. We came to the point we have this accreditation, and on a regular basis we are ensuring that we are implementing the standards to be in the best practices. And that's all from my side. If you have any question, we can take it now. Thank you for your listening. And always, as what Prince Sultan saying, that together we care. So we have that vision, and we are always trying to help the people to help themselves. Thank you. I appreciate it.
شكرا جزيلا للمحاضرين الأعزاء. الآن وصلنا إلى نقطة النقاش. أذنتوا لي بس أستأذن المحاضرين الكرام، وإن كانت ربما مفاجأة نوعا ما، أحتاج مسج بعد ما أبدأ مع الكومنتس من جميع الحضور. نبغى تيك هوم مسج من الدراسة اللي عملتها، لأنه زي ما تشوفون ولله الحمد يعني التنوع رائع جدا. يعني بدينا في سي بي، بعدين رحنا الموتيف سكلروسيس، بعدين رحنا البتور، بعدين تكلمنا عن موديل اوف كير مدينة سلطان، بعدين تكلمنا عن البريتيرم والخدج وكيف البايوميكانيكال فيتشرز والووكينج عندهم. فتنوع الحديث يمكن هذه هي الصعوبة اللي واجهناها في لجان اللجنة العلمية ولجنة التأهيل الفرعية في الملتقى، انه كيف نغطي اكبر عدد من البحوث ونكون متنوعين ولا نكون فوكست فقط في مسار واحد. خلصنا الى هذه المحاضرات الخمسه الرائعه اللي فعلا كلها لها محاور كبيره. ما اتمناه من زملائي بعد استماع للاسئله هي فرصه لاستذكار ما هي التيك هوم مسج. اقصد في التيك هوم مسج اتمنى انها تكون دايركتد اما لمختص في التاهيل الطبي او لمستفيد من خدمات التاهيل الطبي او لمنظومه. المنظومه ربما تكون جامعه، ممكن تكون بروفايدر. البروفايدر ممكن يكون مقدم خدمه، ممكن يكون مشرف على مقدم خدمه. اتمنى التيك هوم مسج هذه تكون as practical as we can. لو كنت في مكان هذا الشخص اللي يقدم الخدمه، ما هي المسج من منظور محور الحديث اللي تناقشت فيه، بحيث ان نطلع في بوتنشال ريكومنديشن. ودنا بقدر المستطاع انه هالجلسه هذه نطلع في توصيات مفيده للمريض، للمنظومات وللممارسين الصحيين. ببدا بعد اذنكم باستماع الاسئله، واتمنى من زملائنا الحضور بعد شكرنا لاستمراريتهم لجميع المحاضرات ونسمع منهم الاسئله. اتمنى اذا كان في تحديد للشخص اللي تبغى يجيب او انه يكون سؤال عام بحيث ان الزملاء المهتم هو اللي يجيب عن الموضوع. بالاضافه الى التعريف بنفسنا، ممكن اغلبنا تقريبا نعرف بعض، بس يمكن مو كلنا نعرف الموجودين، فاذا في احد له اي استفسار. انا اتمنى استاذنكم من اول استفسار مع بروف سامي هو عن التاهيل الطبي. يمكن اغلب اللي في البانل درسوا من الدكتور سامي، فامس كنا سعيدين جدا في وجودك يا دكتور في الحفل. فنستأذنكم جميعا من اول توك يكون مع دكتورنا الغالي بروف سامي. اذا في مايك مع الدكتور تفضل توصل المايك بروفيسور سامي. هو الوحيد اللي ما يحتاج يعرف بنفسه. رجاء دكتور لا تعرف نفسك لانك علم لنا كلنا، استفدنا من علمك الله يحفظك.
شكرا دكتور فيصل، وسعيد بالاستماع للمحاضرات اكثر من رائعه. عندي عدد كبير من الاسئله، لكن ابغى اكتفي بدكتور عبد الله واختي هنادي الحارثي، وان كان في فرصه قد اطرح سؤال للاخ احمد. دكتور عبد الله، البارتيسيبنت ايج جروب 4 إلى 7 years old. HM procedures so annoying, so painful. How did you manage to control this A? B, which nerve you evoked and which muscle you recalled from? You listened excellent, but these are missing points we need to elaborate on. The second question, they are 4 to 7 years old. How did you manage to make them relax to do Ashworth scale? هذه سؤالي السبيكتروم of the multiple sclerosis worldwide. My question, why haven't you identified using expanded disability status scale? Let's identify moderate, mild, moderate, and severe, and you select one of these to give you an excellent, precise result. These two ways.
Very nice questions. So yes, you are right, yes. We find difficulty in doing our procedures. Not only that, but we are sometimes missing some of our participants. Choosing of 4 to 7 years old, the surgery is not indicated according to the practice and research. It's not indicated until the kids is 8 to 10 years old. So we cannot leave the kids without more conservative treatment. So our patients in both groups, they're receiving both technique. It is very concentrated treatment for both groups. About the additional treatment of the mobilizations, at the end, you need the HM ratio. It wasn't that compatible like we're doing with the kids, but we done it. Regarding to which muscles, it is the soleus muscles. It is the nerve that we put it to be honest anterior. We put it in the stimulation was in the popliteal, exactly in the popliteal fossa. I know the study was very tough study, but it's good that is we have now a method. A method. It's not a method. It's not a new thing, but it is more commonly used, as I said, in the stroke patient. It's very important. It's good to hear these kids would do with this kind of mobilization in the intervertebral, particularly in the lumbar and the pelvis. It was good. I think we missed the part of the follow-up, but I think in the near future, if you're looking for the long run, the effects of our treatments. We had an addition that is, it is now, I know there is some multiple interventions, but we couldn't really take patients or take kids without giving them anything. Also, I'm and also all of us, I think you agree with me that there is one single treatment can sort these problems. So combinations of treatments. So we avoid really the medical things. You know, many of the medical doctors, they are using narcotics, and you know the consequences of doing that. So there is some side effects in that, unless there is coordination with the rehab team. Thank you very much. I think it's a very nice question. I hope that I can answer your question. Thank you, Prof.
Thank you, Dr. Sami, for this question. It is a great question and important to put expanded disability status care in MS researches. But the reason why I didn't put it because when I recruited a sample, I didn't recruit it only from the hospitals. And during the COVID-19 pandemic, درجت إني أجمع data from also from جمعيات خيرية. I had patients, multiple sclerosis patients, who volunteered to participate. So I didn't have any information from their medical files because they came from different hospitals. So they need to take this information IRB, and it needs process from the process. So in Big Heart University Hospital, they have already in their files, but I found that a lot of missed data. So I prefer to only put in the inclusion criteria patients who are able to work with or without assistive devices.
Just a comment about your question about the HM ratio. Actually, it is a general comment, not related, of course, to the study. H-reflex is one of the late reflexes in electrophysiology, where we are testing the proximal responses of the nerve, or the roots mainly. Usually we use HM ratio to signify the upper motor neuron lesion. Usually it is increased. There is a specific ratio or range for H over M response of the muscle, and whenever the HM ratio is increased, it signifies an upper motor neuron lesion. It is used in pediatric and other population, of course, where we are stimulating the tibial nerve and getting the response from the gastrocnemius muscle for the M response. And of course, when with some maneuver, we are doing retrograde stimulation to get the proximal response from the spinal cord. Of course, electrophysiology in general is a painful study, whether it is electric or by nerve conduction, by needle, the stimulation for the EMG. But actually, the children are tolerating it, and we are performing. يسمونها معسكرات الألمان وإحنا بنعمل. Sure, I tried myself actually, on myself. Yeah, it is very painful, but what to do? Sometimes we are resorting to painful methods just to diagnose.
If
you are not relaxed, you are not going to get an appropriate result. It is too harsh to H reflex and M wave as well. If it is H reflex, might accept it.
Submaximal.
It is acceptable H reflex. For me, I don't use HM ratio at all because I know it is painful for the adults. So no way I can do it on kids. So usually I go for the H reflex. It is even the H reflex, it is painful. Okay, but it's still acceptable for adults. For kids, I doubt it we can do. For me, I cannot do it that. I'm maybe too sensitive to deal with, too sympathize with the kids, to punish him to do that surgery code. So I don't do it for them with the kids. Okay, so H reflex acceptable. M wave H reflex, I think, cannot be recorded properly. So the result will not be appropriate. We cannot, for me, I cannot take the study as a serious, though it is important to me. Okay,
شكرا دكتور، الله يعطيك العافية.
يعطيكم العافية جميعا. سؤالي للدكتورة ريم، حضرتك تفضلتي في البحث اللي انت سويتيه على مستوى المملكة انه التدخل المبكر، وتكلمتي عن أهمية التدخل المبكر. بس فقط للمعلومية إذا ما هي عندك ولا للجميع إنه إحنا عندنا برنامج التدخل المبكر للإعاقات. Yes, just I want to consider this if you don't know about it. Thank you very much.
يعطيك العافية. أنا عارفة إنه موجود بس إنه still implementation حقتها لسه يعني شوية متأخرة بالنسبة للإفدنس اللي موجود. الحين الإفدنس آخر شيء لأن بالنسبة للحين يعني زي مثلا أستراليا ودول كثيرة لما طبقوا ال detection and the NICU صار الحين عمره التشخيص مثلا زي السي بي صار يتشخص بالعمر 6 شهور 60% أو 70% يكونوا مشخصين already. واحتفلوا السنة اللي فاتت إنهم نزلوا قلل الريت of motor environment هذا شيء وزيادة السيفيريتي according to مثلا السي بي مثلا السيفيريتي قلت. فهذا إن كل ما كنا أبكر أوكي إحنا قاعدين نحاول implementing بدري بس المفروض يكون لسه في النيكيو we need to work on it more يعني. هذا الجواب. ولا أنا عارفة إنه موجود وإن شاء الله شيء جميل بس we need to implement more highest evidence زي general movement assessment الحين it can be done at the NICU within 3 trajectory تقريبا أنا 3 شهور you know this child 95% will have CB. You can predict at 40 years he will be walking or not with assistive device or not. All this evidence now available, and that's why we need to implement it. Maybe like a center of, but it's need advanced certificate. I have the advanced certificate, and I think it's need to be implemented. Like other country now working on it also to implement as a level of governmental.
It's very good to be concerned. Yeah, with the should be one of the tools that they are going to test. The babies.
الحين قاعدين نكتب proposal لوزارة الصحة implement more assistive device على النيكيو overall as a presentation أو يعني physiotherapy with that it can be done also by OT.
عودة سامي أو تلاش الريفلكس. بس في النهاية ترى أنت you need objective assistance. ما أقدر أنا أبعد هذا الشيء على subjective يعني زي الأشفاط وزي المشاكل. أنت you need في النهاية. I think the usage of this implementation of this gives me a big experience. Also increasing also the stimulations gradually. I think there's some sort of the main thing is we need something which is really an objective measure.
شكرا لكم. إذا في أي استفسار أنا عندي أعلق على تعليق الأستاذة ريهام بعد ما أسمع منها. أنا بكون آخر واحد بيسأل. حفاظ على أوقاتكم. تفضلي.
مرحبا شكرا جميعا. أنا شهادة الخليفة أخصائية علاج وظيفي. سؤالي الدكتور أحمد صراحة يعطيكم العافية. احنا من النماذج اللي نفخر فيها دائما مدينة الأمير سلطان في الخدمات التأهيلية خصيصا احنا الأخصائيين في التأهيل. يعني نموذج ما أشوفه بس محلي إلا هو قد يكون عالمي في الريادة في التأهيل. لفت انتباهي نقطة ذكرتها من الأشياء اللي المدينة تهتم فيها اللي هو staff culture. This is يعني a very important point. لكن سؤالي كيف if you don't mind to give us an example of the change that implemented في المدينة and how this affect خصيصا المدينة is kind of business model and how this aligned with the vision of المدينة. وشكرا يعطيك العافية.
Yes, first of all, the safety culture, and we have measured that both sides. For the patient, before we handle any case, we need to ensure the medical record number, reporting by the patient name and medical number. This is all in the IPSG standards. For the staff, first of all, education. Giving the staff the awareness about the importance of reporting any clinical issue happens with them. They are working in a different shift for more than 8 to 9 hours, so they need to ensure that whenever they are experiencing any things that they have to report it. And also the consequences of reporting things is not going to be reflected somehow on their performance. This collaborative work happened between the departments, nursing, rehab, medical. And the top of that, the human capital management, because they need to ensure some of the processes supporting that, and all of these things is implemented. This is one. Second, the risk management department, they ensure that there is a system is linking and easy to be accessed for the staff to report anything that happens with them.
Okay? In this case, when they report any fault, when they report any medical or medication administration mistakes, it has to be something safe, not reflected immediately on the staff. We start with a lot of workshops about just culture to enhance the staff awareness about how we can do corrective action for any mistakes happens. There's a difference between slips, mistakes, and reckless behavior. So in this case, we can educate them that yes, you should report. And also, what I mentioned about leadership round, I personally tried that. When you go and move and discuss things and daily operations with the staff, they will have open experience to talk to you, to provide all the feedbacks and improvements that might be something as a leaders we don't see it. They are seeing the patient on a daily basis and things can make difference. Maybe for us it's regular, but for them it's something important. I don't know. I hope that
شكرا جزيلا.
Assalamu alaikum. My name is Mehmet Arif. I have a company, a consulting company in United Arab Emirates, and we are supporting governments in terms of medical rehabilitation. I heard that Mr. Abdullah Shankit is here. Just to talk to him, to give him some information what you collected regarding the amputation and P&O here in Saudi Arabia. And coincidentally, I heard that Madam Dr. Ines is also working on this issue and was making a research for amputation. So, and back in 2016, we've been contacted from Ministry of Health under the umbrella of Dr. Tarif Al-Amma. He said we would like to improve the P&O system here in Saudi Arabia. And we asked him for a permission to make a survey inside of Saudi Arabia so that we see what kind of challenges we have and according to the outcomes to give our advice. So it is not a question, it is an ad, but I would like to talk to you. We make research for analysis. We said, okay, how can we find the data? So we couldn't find it. It was a survey in 1993, which was made. And then we said, okay, let's do it by our own. So we traveled the whole kingdom. We started with Qurayat, Arab, Sakaka, and Tabuk. Went to Najran Bisha, and also from Hafrul Batin to Jeddah, Tamam. So we made the whole survey within the whole kingdom, and we collected all the data that you collected in Sultan City for all the ministries, hospitals. So my idea was to talk to Mr. Abdullah Shankiti to give him this information that you collected. Unfortunately, due to the corona issue, everything was on hold. And since Taiwan University has the P&O department, and they have a beautiful program for the P&O students, I want to make him this data available. So you will have actually a doctor soon, I hope, will have with Dr. Shankiti data available, which is from collected all Ministry of Health hospital around the kingdom, and also the causes of amputation. And yeah, so we'd like to link you then later on to it, because I want to make him this information available, and also for his students, so that they can contribute something for Saudi's P&O service. Thank you.
Thank you very much. أنا حاول ننسى أهرب منك وش الله طبعا هنا we have two studies published 2022 about the amputation عندنا دراستين talking about the وجدنا إنه في جنسيات معينة there is some certain nationalities especially for the traumatic amputations more than the South. الناس الشغالين اللي هو الباكستاني هذا بعد السعوديين طبعا الباكستاني people that are working in the building لاحظوا إنه الناس اللي شغالة في البلد building and participating in that they have more confidence. Actually we have all 5 إن شاء الله with this إن شاء الله الناس دراستين إن شاء الله جميلة published السنة هذه كامل share information and نستفيد منها إن شاء الله benefits provided from our colleagues. Thank you for coming. Thank you for also for following me.
شكرا دكتور عبد الله. هل في استفسارات أخرى؟ تفضل.
السلام عليكم. معكم الكوتش محمد الشامي. أنا مدرب رياضي وكذلك مختص لبعض الإعاقات والبترول. للأسف الشديد يعني أول شيء شكرا لجميع القطاعات الصحية والمراكز، بس للأسف العلاج الوظيفي والعلاج الفيزيائي ما هو مطبق بشكل احترافي عالي جدا للي عندهم بتورة واللي عندهم إعاقات. أبغى يعني ما شاء الله تبارك الرحمن كانت في البحوث العلمية أو الدراسات ما شاء الله تبارك الرحمن ماخذين المراكز الأولى، بس كأرض الواقع للأسف ماخذين المقاعد الأخيرة، فإيش السبب؟
طبعا هذا السؤال عام بشكل جامعي. الله يعطيك العافية. يمكن أنا من أول تعليق كنت أقول هنا نطلع إلى براكتيكاليتي، نكون مرة عمليين ودمج الابحاث والنتائج بالواقع. لعلي اخلي استفسارك هذا اخر استفسار، لان احنا عندنا من المحاضرين الاعزاء بنناقش ما هي تيك هوم مسج لكل واحد. يمكن انا بحاول كل محاضره الان كيف نستفيد من البحث حقك لنطلع يعني توصيات من هذا الملتقى، نخرج بتوصيات حتى للباحثين انه ممكن نطلع ابحاث تطبيقية أكثر ما أنها تكون علمية. نحن نحتاج الطرفين، نحتاج العلمي نعم، وأيضا نحتاج التطبيقي، ونحتاج نسمع من الطرف الآخر. يعني أنت الحين very good example إنه أنت تقول في أرض الميدان أنا ما شفت كثير من النقاط، فخلنا نخلي آخر استفسارك وبإذن الله أنا أحاول
أعتذر السموح. أنا رحت ألمانيا للأسف الشديد ما شاء الله بحوث علمية ما شاء الله فوق الخيال، أما في أرض الواقع ما هي موجودة. رحت دبي كذلك ما هي موجودة، رحت أمريكا كذلك ما هي موجودة في أرض الواقع. يعني كعملية يعني كشخص مستفيد ما في، بس ما شاء الله البحوث العلمية ما شاء الله تبارك الرحمن.
واضح. طيب
محمد ما شاء الله أنا شايفة معك advanced prosthesis.
هذا الجيل الثالث وللأسف سيء.
If you measure on this one أكيد راح تشوفنا لأنه this is very advanced. It will need comprehensive training, and from Germany to Saudi Arabia we know this is something. It comes to the patient himself. If the patient didn't get the training, therapists they are just trying to help him to practice the like to be more adapted with the sensors. It's very advanced. ما شاء الله تبارك الله. But your point is good. We'll back to that
استعمله يا محمد؟ تستعمله كويس؟
أنا أستخدم بس معليش للأسف هذا الجيل هذا من أسوأ المواد. معليش أفضل مادة لصناعة الأطراف الصناعية والأطراف المتحركة وهي نانو كربون، هي أفضل مادة لصناعة المواد الأطراف المتحركة.
ما نتكلم عن مواد بقدر ما إنه يحتاج مهارات.
المهارات معلش كخلايا عصبيه الطرف نفسه المبتور اللي عنده لازم يقوي نفس العضله اللي عنده. اذا كان جسمه رياضي لازم يقوي العامل النفسي والعامل الجسدي عشان يقدر يحرك الطرف. اما كذا ما يتحب ما ياخذ خلاص يحطه على جنبه بس.
صحيح. الله يقويك.
شكرا لك على الملاحظه، وبدنا نعودها مع نهايه الدسكشنز. هل باقي استفسارات؟ طيب تفضل. Back is sir?
No, I just want to add something
okay.
to what he said.
Okay.
Actually,
take the mic again, please. Sorry.
Actually, you said it was sounding like it's a rocket science. It's not at all. So it can be available in Saudi Arabia. We have it also in Saudi Arabia. And the only issue is that it is not well distributed in Saudi Arabia. And this was the reason why we said let's conduct it. It is if our responsible people in the Ministry of Health, if they sit together, okay, we can have a system from Riyadh till Najran. We can have a system where they can offer exactly the same prosthesis what the gentleman is wearing. So we don't need a Sultan bin Abdulaziz everywhere around the kingdom. It's okay if we have
for very hard cases here in Riyadh. For all the rest of the kingdom, it's more than enough to have a satellite.
Just
so, and so
I can elaborate here, because now we are talking about producer, manufacturer, needs. So I'm going to talk about this later. I'm the Assistant Deputy Minister for Hospitals at the Ministry of Health. So don't worry, I will answer all of your questions. But just let's postpone it to that, okay?
السلام عليكم ورحمة الله وبركاته. معكم إلهام الجمالي، طالب دكتوراه في جامعة الإمام، تخصص خدمة اجتماعية تخطيط السياسة. طبعا أنا راح أتكلم الآن في تخطيط السياسة بعيدا عن الأشياء الثانية. أول شيء أنا شرف لي التواجد في مدينة الأمير سلطان لمدة شهر كمرافقة لإحدى الزميلات. صراحة هي وجهة لكل يعني ذوي احتياجات خاصة في العالم محليا وإقليميا. الاستفسار الأول إن شاء الله يعني ما هي معوقات إنها تكون وجهة عالمية. الشيء الثاني بدأنا النسخة الثانية أو الفرع الثاني في مناطق المملكة. لماذا التمركز يعني في مكان واحد بس؟ الشيء الثالث هو مقدمة استفسار الأخ والحاكم ما شاء الله في استثمار جيد. هو أعضاء الأطراف يعني جدا غالية. متى نرى إن شاء الله بإذن الله تصنيع الأطراف الصناعية والأجهزة الطبية في مدينة المستقبل؟ لأن أتوقع ما شاء الله عندهم التجارة والأبحاث، فما هي العوائق؟ أهتم بالعوائق لأن هي مجالي. شكرا.
شكرا لك.
أولا شكرا على منحك مدينة الأمير سلطان بن عبد العزيز. طبعا يعني أضم صوتي ليكي لأن الخدمة اللي عندنا زي ما قلنا مالتي ديسبلينري سيرفيس، فأكيد المالتي ديسبلينري سيرفيس حتنتج خدمة أفضل. بالنسبة لسؤالك الأول كنت بتسألي عن الفروع. احنا حاليا في يعني إن شاء الله في 2023 في فرع هيفتتح في مدينة جدة. إن شاء الله يعني بنهاية 2023 عشان ما نبقاش بندي بروميسز قبل كده. الحقيقة في مدينة سلطان هو احنا مش بنصنع الطرف، هو الأجزاء بتاعت الطرف بنستوردها يعني بتستورد، والتجميع بيحصل في مدينة سلطان، وبعض الأجزاء بتصنع فعلا في المدينة في ورشة البروثيتكس اند اورثوتكس اللي عندنا. كان في مشروع بس يعني هو مع نرجع نقول تاني ان هي يعني زي مدينة أبحاث ان احنا نصنع البروثيتك هاند هاي تكنولوجي زي مايكل انجل مثلا، لكن الحقيقة لسه يعني في طور زي ما بنقول يعني in process، لسه ما فيش results دي.
شكرا جزيلا. طيب يلا تفضل.
مدينة الملك عبد الله للعلوم التقنية اللي في جدة، ليه بدل انكم تخاطبون المانيا تخاطبون مدينة الملك عبد الله للعلوم التقنية، عندهم ما شاء الله مخترعين مصممين حتى الجيل الرابع والجيل الخامس عندهم كذلك.
هو الحقيقة في زي ما قلت يعني زي تعاون بس هنا في الرياض، مش في مدينة مش في يعني في أماكن ثانية. لكن طبعا يعني قسم الأبحاث عندنا يعني willing إن هو for any contact for the benefit of the patients and of course the healthcare providers.
شكرا جزيلا. آخر استفسار، تفضلي.
Thank you so much, all of you. I just want to add a comment. Dr. Abdullah mentioned that the amputees are more other than the Saudis. So I have one patient. He's Pakistani. He's with me here, and he actually was raised like he was born and raised up in Saudi Arabia. But being Pakistani, he was not treated obviously the same way, and he had the amputation till the shoulder, and he asked for the prosthetic limb. So the cost was really high, even for the robotic arm. So he actually went back to Pakistan, and he received this robotic arm. So he's here. It's just a comment to add to what he said, that the amputees are other than the Saudis as well. So we have one case with us, like he suffered because obviously he's not Saudi. So if you want to see maybe at the end what he can do with this yeah, thank you.
I think we're going to discuss it after this session because the equity is here, Saudi and non-Saudi, but the eligibility criteria differ. That's all. It doesn't mean that if you're not Saudi, you are not taken care here. But the eligibility to be treated for free, this is the main difference. So let's discuss this after, see how can we support this through any channel that will suit his case. So now we reach to the end of the discussions from the الحضور. أنا برجع نفس السؤال الأول وأبغى أحط الصوص البراكتيكال على كل دراسة. أبدأ من مدينة سلطان بحكم إنه يعني نقاشنا عن مدينة سلطان. It doesn't mean وجود مدينة سلطان هنا نتكلم عن جميع خدمات التأهيل. نتكلم عن one of the best. نتكلم عن NGO، نتكلم عن مدينة تقدم خدمات رائعة جدا كلنا نفتخر فيها، ولكن they can't talk about the national level because they are not the national provider for the healthcare at the Kingdom of Saudi Arabia. The national provider is the Ministry of Health. We do have about 287 hospitals and 2,200 primary health care dispensaries, PHCs, as well as we have 228 physiotherapy departments, 16 P&O departments. So this is the national provider for the healthcare, as well as I can add that we are providing only 63 all over the kingdom. We have private sector, we have NGOs, we have a non-related Ministry of Health, we call them like other governmental entities, like the military hospitals, the National Guard, the hospital, the university hospitals. They do provide the healthcare services. They do provide even the rehabilitation services, like the military hospital and the National Guard. They have even rehab beds. They have P&O departments. So if we can encapsulate, now we are doing 63 and 38 for non-MOH related entities. Now, Medina Sultan, they talked about the model of care, which is amazing. I like the talk about the model of care internally for the Medina Sultan. But if we are talking about the model of care at the Kingdom of Saudi Arabia, now we are transforming. Before we are treating people in our hospital, in our entities, with a hospital or rehab department, but the system was fragmented. Hospital-based or rehab-based. Now the transforming to the Vision 2030, we are dealing with this as a journey. It's a real journey. So that's why Ministry of Health, now we are counting down in a couple of weeks. So we will start our new role, which is polycystic. We will not deliver a care like before. The delivering the care will be through a Saudi a health holding company. They are the arm to deliver the care. So they are now accountable for clusters. We will have more than 21 clusters. The clusters will be accountable for their patients. They can't deal with Medina Sultan. The cluster themselves, if they need something, they will go with Medina Sultan to collaborate, or they can manufacture, or they can build up a capacity. They can do whatever they want for their catchment area, because every single cluster differs from others. So a cluster in Riyadh, you might say, okay, Ibn Sultan is near to me, I will go there. I'll make MOU between the cluster and Medina Sultan with a purchasing program or private sector participation, invoices, payment per service. It's nothing to do with the patient. This is actually from the two providers, G to G or G to government. So now, to make it a sauce here in this talk, Medina Sultan, they do a very good model of care. But I'm asking them now, how can we make sure that your model of care suits our model of care? Now we have 6 domains in the model of care. We have chronic patients in a very clear area for us. Chronic, they should go for a cycle. So if I have a patient, let's say stroke patients, I can't deliver a rehab for them. I transfer them to Medina Sultan. They will treat him, and then he will get back to the same cycle because he is with me now. I'm a cluster, so he's with me. He's my patient. I would expect from Medina Sultan to treat them 100%. But still, I have other expectations from Medina Sultan. What can you deliver for me? إذا عالجت مريض وخلصت البرنامج التأهيلي، أنا عندي موديل اوف كير. الآن المريض disconnected راح لمدينة سلطان أو للبرايفت let's say private. And I'm not talking about Medina Sultan as Medina Sultan. He is disconnected from my model of care. And so what is the, let's say, potential recommendation from this conference? كيف نضمن استمرارية الخدمة من السايكل كاملة if you deliver a care for him. So المريض أحتاج يعطيني full detailed report، أحتاج أتأكد البيشنت continuity عالي جدا، أحتاج أتأكد إنه تعرف أنا وش قاعد أقدم له وش راح أقدم له بعدك، عشان ما يكون السايكل هذه blinded بالنسبة لي. So بسمع من الطرفين الدكتورة والدكتور عشان نغلق موضوع سايكل مدينة سلطان بعدين نتكلم عن الدكتور.
First of all, Professor, thank you because you answered 5 questions in one talk. Plans always change. Before Corona, before the implementation of the Vision 2030, it was there is some strategic plans in Sultan City. Like to answer the branches, there was different plans to open in Khamis Mshiat in Jeddah, even to go international, to go to Emirates and other GCC countries. But sometimes with other strategic plans comes, you need to make some breaks and restructure. Maybe Dr. Ashi remember, and we attend a lot of repositioning and restructuring plans happens within the downtime of Corona period because it was affecting that maybe the number of patients referred. So we have time to do restructuring. We did different like collaboration with the Shirley Ryan Ability Labs, which is the rank #1 for more than 30 years in USA for rehabilitation, to get this shared and join the experience, so we can build our capacity in that. Now, how we can transfer the model of care to the Ministry of Health and the others? This affects opening the branches. Sometimes you don't need to go and do satellite clinics in different countries. What we have Ministry of Health hospitals. Just you need to share your experience, policies and procedure, evidence-based clinical pathways, so we can implement it. No need to open different branches for Sultan, different branches for Al Musa, different branches for other hospitals. Just we can utilize whatever resources first available, then we can enhance it further. Based on that, we can look where is the gap and we can enhance it further. And from here, I think the efforts all works together in parallel with Ministry of Health to know what's their strategies to be taken from the vision of 2030, implemented in all the areas of the healthcare sectors. Sometimes you need to stop, to look where you are and what you need to do more in the effort to enhance it further. This is one. Second, regarding Ministry of Health and how they are referring the patient, now it's different than before. Insurance companies, we all look for the value-based system, not anymore like before, it's just the quality of service. Now we need it in a limited length of stay, patient can take the service, patient has to be admitted, not to be less in the waiting list for a long period. Some patients, they will have the stroke, they will struggle to be admitted because there is no chance, no bed, waiting list is very long. Now that's not available anymore. 5 days, if the patient not admitted, will be moved from Sultan City, will be taken to other hospital. It will be a chance for all patients. And that what came from the Patient Experience Summit. It was organized by the city, by the Ministry of Health before, that the patient is in the center. All resources in the kingdom has to serve that the patient will take the service as soon as possible. There is, I'm not saying there is, we are in the best model, but always there is a chance to improve. At least we have to work on that.
شكرا جزيلا. أنا بس عشان الكوشس about the time, can we say دكتورة أو دكتوري إنه من البوتنشال ريكومنديشن إنه أي منظمة تقدم خدمات التأهيل الطبي يجب أن تحرص شديد الحرص على البيشنت كونتينيوتي أو الكير كونتينيوتي. ما نخليها باسم مدينة سلطان لأنه الآن عندنا 4 بروفايدرز يقدمون inpatient rehab من البرايفت سيكتور. مدينة سلطان الآن في مستشفى رعاية في كامبريدج في الدمام. في عبد اللطيف جميل، هذول 4 بيلرز للقطاع الخاص، يعتبر اذا قلنا مدينه سلطان قطاع خاص وهي ليست قطاع خاص. فيمكن هذه بوتنشال توصيه انه يجمع الخير اللي يقدم خدمات تأهيل طبي ينظر لما بعد برنامجه ولا يكون كروس سكشنال لونجتودينال اكثر ما انه اذا شيرنج نولج، شيرنج اكسشينجينج البيانات and looking at the big model of care of the kingdom. Now it's a one model of care. حتى البرايفت they will go within the model of care. تأكد أكثر إنه نمشي في خضم رؤية الوطن. اخر استفسار في مدينه سلطان موضوع الاطراف، هذا كان مشترك بين طيبه وجامعه سلطان واستفسار زميلنا. I have to be cautious about delivering data that you have to other entities without taking permission, because you are not, still you don't have permission, because you are not a scientific, let's say, paper or a scientific study that you are doing, or trying to make sure that you deliver data through a scientific work. So please make sure the data that you have, unless if you have a permission from the entities, even if you have it from Ministry of Hospitals, sometimes you can't. I'm pretty sure that you can't deliver the data that you have to, even if it is other governmental entity. Data protection here in Saudi is very robust, constructed. If you would like to make it, if you are talking about the kingdom, we have gates, like universities, even the hospital, they can't give something about the kingdom. Ministry itself, مجلس الخدمات الصحية, Saudi Council for Health Services, or a university, they will talk about their university. So I would suggest, if you have any data that you would like to go further for it, make it as a paper. We have universities today here, they can go with us with permission, we can give them, we can't give a permission to a manufacturer. We can't, because it's driven by a manufacturer error. I will discuss it with you later. Sorry.
I'm not a manufacturer.
Okay.
It should not be misunderstood.
Okay.
I'm a consultant, so I'm consulting, for example, Kuwait,
with whom?
Oman. Consulting.
With whom? With whom? Consulting with whom?
With Ministry of Health.
No, I'm the Ministry of Health.
I used to talk with...
Talk, but still you don't have the permission. That's why. Let's discuss it later. Yeah, let's discuss it later. Take the permission, and we are happy. You are trying to support us. Exactly. But it's not the good gate. If you would like to provide the data, talking about the Kingdom of Saudi Arabia, you should go with the Ministry of Health, take a permission, and then go anywhere. Or go to a university. Today we have a very robust universities, leaders, experts. Go with them, make sure that you made the proposal, and then they will take permission from ministry. And I'm not going to talk about Jami'ah Tayyiba because I don't have the permission there. They are an educational institute and provider. So yes, you are doing good study that will serve all of us, but you have to change the gate. So we might say, okay, even other potential recommendation that making sure that the data protected, if you are talking about, especially for sensitive topics like eligibility, statistics, amputees, so still we have to be cautious about delivering the data. You might have data from here, and then we'll go to WHO within contact with the WHO, maybe personal contact with WHO, might misinterpret to the kingdom. Thank you again for your support. للاسف احنا حاولنا اليوم ان نختصر، يبدو انها exceeded time 3 minutes الان. انا اعتقد انه خلصنا فيما يخص مدينه سلطان، تكلمنا عن البوتنشال كولابوريشن، الابحاث الثلاثه من زملائي، انا اوعدكم بجلس مع زملائي، بحاول نطلع بوتنشال ريكومنديشن، اذا في احد منكم عنده اي اهتمام او عنده، هي فرصه الان انه ندخل توصيات من خلال هذا الملتقى الرائع جدا. I'm here بس we have to close عشان الحفاظ على الوقت. نبي نناقش اذا في احد له كومنت يرى انها مناسبه نوعدكم ندرسها توجذر، وباخذ من زملائي ايضا بعض الملاحظات وندرجها في زي الريكومنديشن او ريبورت اوت من هذه الجلسه اللي باذن الله تكون مفيده لزميلنا اللي اعطانا. يعني هذا هي الاجابه اللي بنسمعها من زميلنا، يقول انا كل اللي اشوفه الان ما لقيت في الميدان. ليتس بريدج الجاب، في جاب بيننا الان، ليتس بريدج. يمكن ما يعرف الان الجاب، ما يعرف الطريقه المناسبه للحصول على خدمه، اتس جاب. المفترض يعرف اصلا حتى بدون ما نقول. فذلك it is one of the recommendation. Let's bridge the gap between المستفيد والباحث والبروفايدر. It's a gap. We have to fill it. تفضلي انا ما اعطيتك مجال، انا اعتذر منك.
هي جاب في العالم كله الحين knowledge translation. هذه كل العالم، كل المنظمات يعني البحثيه قاعده تشتغل على knowledge translation، انه اوكي قاعدين نشتغل فدنا الباقيين، وصل ما وصل، هذه اجتهادات لازم الاخصائي يروح يدور، لازم اننا نسكر هذه السيركل، الجاب هذه، هو knowledge translation ترى شيء كبير مره، وانه جاب في كل مكان، زي ما قلت حتى في المانيا مثل ما في جاب في الاستشفاءات او هذه، فكلنا قاعد نشتغل عليها وان شاء الله باذن الله ان هذه نقطه مهمه لازم نشتغل عليها.
وانا اضيف زميلتنا الاخصائي الاجتماعي، دور الاخصائي الاجتماعي برضو هذا من ضمن ادوار التأهيل الطبي، ترى الاخصائي الاجتماعي له كروشال رول في خدمات التأهيل الطبي، انا درست الباك جراوند حقك مع انه مو نفس السؤال، بس انه دور الاخصائي الاجتماعي انه يوصل المعلومه للمستفيد بطريقه اخرى، مو شرط انه يتوقع ان المريض يعرف اللي في مخه. فدور الاخصائي الاجتماعي بيكون ان شاء الله كروشال.
بس اضافه بسيطه، انا اتوقع لتغيير الكلام هذا او لتقليص الكلام نعيش مكان يعني اذا انا اعيش مكان ذوي الاحتياجات الخاصه، هذه التجربه عشناها في جامعه جده لرفع توصيات للجهات المعنيه لذوي الاحتياجات الخاصه، وكان للاسف الشديد انه احنا نشتغل في اعاده التاهيل ذوي الاحتياجات الخاصه ولكن من دون التنسيق مع الجهات الاخرى، مع البلديات وهذه الاشياء. هذا واحد، انا اتوقع التنسيق والعمل مع الجهات الاخرى راح نصيب الهدف. هذا شيء لانه احنا عملنا لا يتوقف، يمتد الى ذوي الاحتياجات الخاصه، يعني ماذا بعد ذلك؟ هذا الشيء الثاني، اعيش مكان، يعني مثلا انا اجلس مكان في الكرسي بحيث اني انا ما اقدر اعيش، ماذا يعني؟ فانا اتوقع لو نعيش مكان احنا راح نعرف ننظر للحياه من منظور.
شكرا جزيلا، وهاف تو كلوز الان، موجودين ان شاء الله وبناخذ التفاصيل، نعرف الدكتور رندا تاخذ وقتك، فشكرا لكم من الاعماق، شكرا محاضرين الاعزاء، اثلجتم الصدور في المعلومات، في التفاعل مع كل الاسئله، شكرا لكم من الاعماق، واتمنى من الله العزيز الكريم ان يفيد في كل ما قلتم وان ينفع المستفيدين منه باذن الله. شكرا حضورنا الكريم، شكرا كلنا باسم حضوركم لمده ساعتين للقاء علمي بحت في اخر ايام الملتقى، يدل على اخلاصكم واحسانكم. شكرا جزيلا.